Hola, muy buenos días.
Esto es una prueba del servicio de interpretación 1212, probando. Esto es una prueba del servicio de interpretación 1212, probando.
Good morning, everybody. So it's a wonderful round table today. But to say thank you, I couldn't do this institutional speech, but I want to say thank you to my colleagues, because they didn't see the full presentation and just came here to debate some cases and to talk about something that I would like, that is ankles and stability. And maybe if we have time, we also consider other parts. So the objective, the goal is to learn how to approach, maybe from we're going to learn anatomy, and together with Michael, we're going to talk about invasive therapies, plantar support, and surgical solutions. And so this roundtable justification is based in the fact that is the most frequent consultation in traumatology, maybe not in podiatry, but this kind of consultations and that comes and say, I've got a pain in the side of my ankle, and then we know that the patient has had some strains, so we can't get that. We can make approach depending on what is really happening. And so we're going to speak about very common injuries. In fact, we're talking about 15 or 20% of our patients. So it is important to treat these patients, these ankles, as it is should. And for sure, we all agree that normally a patient with an ankle strain comes and says that this was not must she have a problem, or a doctor said I should immobilize, or to said no. So let's try to focus on that. And the injury mechanism, as we're going to comment now, is something quite problematic that we are suffering. And then and that is one of the main points that Dalma will try to clarify, is that concept of a chronic instability versus a functional instability. And we are going to have a look to objective tests, and because we know that normally it is the patient that feels this instability. So we've got a concept of instability and micro instability, and all these anatomical uh, injuries that Dalma is going to comment, and also the rest of the members of this round table. And so I'll give the floor to Michael Dalmau, Dr. Michael Dalmau. My objective is that you solve all your doubt, or at least you try to learn something for your consultation from today. So good morning, everybody, and thank you very much, Pedro, for your. So it is Michael or Michael? All right. So thanks to all of you, and thank you to the organizers for the the kind invitation to be here today, and to Pedro for all the job he has done to prepare this panel. So it is nice to have a roundtable speaking about anatomy. It is not quite common in podiatry congress. So, and the topic something I really like. And it's the result of the last my last 10 years of work. So we're going to speak about this anatomy of lateral ankle instability. We all know what the strain is, but not everybody knows all the last developments at this regard. It is clear that we all know that the ankle sprain is quite frequent, mainly in young people, and for sure you all know one person that knows this um, strain that were not well healed. And it normally has quite quick consequences from proprioception and at a neuromuscular level. And we know also about these, what happens after an ankle sprain. We normally speak about the 30-40% of chronic pain or a way of instability, or this new concept of micro instability. What we also see is that many of these patients choose to have used to have an evolution towards the um, soft tissue impeachment. It is something we knew since the 80s, and in the 1916, we highlighted that there is no something called simple lateral ankle sprain. So it cannot be simple if you have a disc chronic pain. The literature is abundant and establishes this relationship between the clinical instability, the development of joint injuries. And recently, that is what I commented yesterday with Pedro, we've got this theory of cartilage crack that says that after a ankle strain, there is a little traumatism between the astragalus and distal side of tibia. And this traumatism will depend on the strain degree. It can be little, it can be small, but it is a cartilage injury that at the beginning it is something you cannot see in in an image test, like an ultrasound. What wasn't that clear at the beginning, it was the reason why. Why is this the relationship between uh, ankle strain and the development of joint injuries? But if you have a look to anatomy, it is clear that inversion ankle sprain is the most frequent one, and so mainly that's going to be the anterior talofibular ligament and the calcaneofibular ligament. As you can see here in a section, there are two separate structures, the anterior talofibular ligament and the calcaneofibular ligament. So if you check all the anatomy books, they were always defined as two separate structures, but it's not it didn't match that much. And so some years ago, we started with this study. Seems to be logical to try to find some connections between both ligaments. And so we changed the anatomy of these lateral ligaments, and we defined talofibular, anterior talofibular, and the other one is here on the number, and also an inferior one on number two that is connected to calcaneofibular through these fibers. So these fibers are here between one ligament and the other. So it is quite simple. Okay, we cannot see. So and thanks to data, we found the definition of the lateral fibulocalcaneal the ankle that was formed by this inferior facade of the anterior talofibular ligament and the calcaneofibular ligament connecting arciform fibers. What is even more awesome is that we realized that the position from interarticular cup and exarticular cup. So it is when we found this superior fascicle, and it's something that we can find here in the ankle. And we did some studies, and we found others wanted to compare that with another paper, and we tried to work here, and we saw this structure, and we see the way it was repaired. So not just capsules, but all the interarticular ligaments, as you can see here. And we want just to see how it works at a dynamic level. And because our findings did not match with the literature. And so we saw that something logical during a plantar uh, flexion in this complex superior fascicle tension and complex tension. So we can see, but we can see that there is tension in there. So if we move this ankle in dorsal flexion, all the ligaments were relaxed. But it's not that clear because the complex, the rest of the complex keeps in tension. And we can see in these two videos. Let's see if you can watch the videos. And it's like you can see here what is relaxation and what is attention. And so this took us to redefine this complex as an isometric structure. We carried out additional studies just to check these fibers and to see if they were robust enough as to support, to stand these tensions. And so we carry out here an indirect reparation of the ligament with some clinical results that were published years ago. And when we take all this to the consultation to the clinic, when we face a patient with a minor ankle sprain, so it's not going to be much difference. It's going to be superior fascicle distension. If we go to the other end, a severe ankle sprain, we can speak about a rupture of this superior fascicle, and even we can have a fibular injury. And so um, the diagnosis is not going to be a big difficulty. And so for us, the big change was when we thinking a moderate ankle sprain, we've got the hypothesis that what will happen if the patient suffers um, an isolated rupture, that's this interjoint. When we speak about kind of the joint that are around the joint at the level of the ankle, it is like you can see what we did in this video. And so we introduce it, and you can see that inside and we have this synovium in this side and the joint. And this is the we're going to find in the anatomy that we know. And so the arm ligaments don't have a capacity, like, they cannot repair by themselves, they cannot heal by themselves. And that is the scheme that was that they defined this healing procedure or reparation procedure, and we know that it's going to be healed over the renin, the rest of the rupture and the ligament, and so this way is when we're going to solve this problem. And so since some years we said, okay, if we've got an isolated rupture of this ligament in a superior fascicle, so maybe it's not going to become a classical angle instability, but we can speak about this concept of microstability. And only when we've got this kind of rupture in the superior and inferior fascicles, and when we're going to have a patient with a classical instability. And so that was quite clear. And in these results match within these statistics of chronic pain. From this point, we developed a lot of research on both fascicles, and it's not easy to find at the level of an MRI. Other things that we found during the study, you are used to this picture here to see it from a side view, but we wanted to look at these ligaments from the medial side. And this medial view, you can see the superior fasciculum, and here you can see the biggest ligament. And here maybe it's not going to be easy, but you see how uh, we can transmit the tension. And if we make a pressure in here, uh, So it is on the local canal ligament. So we see how they are interconnected, and you can see in this picture where we opened the talus bone, and so we can and we started defining the same at this lateral complex when we've got this connection with a three component. And at the end, all this investigation took us to this study that maybe it is the final point of this explanation, where we assessed what was the function of anterior talofibular ligament superior and inferior. And so we've got this a robot in London. We tried to make rotation valves and so on. And at the end, we found out that the superior fascicle makes an internal rotation. And to the inferior fascicle, talar in anterior translation. So when with an examination on a patient, when we try we see there is a instability, normally we do that from the rare part, from the and so this patient with a micro instability, because we see that it's not positive, so we are applying a test that shouldn't be done. We know because if we know that there is a limitation in a specific part of the body, we can have a patient with a superior fascicular rupture that always show you a negative result with the test. But if the patient has an interior and lateral, so in this way, it's going to show this instability. For a long time, we tried we're thinking about what would happen with an MRI if it was something, if it were very easy to see or not, these particles, and we carried out this study, and what maybe cannot be applied to all the image service diagnosis, but applying a protocol, we can see all these joint connections, and we can see the fascicles, we can see the anterior and posterior connections. We also can see the artery that is in between the superior and inferior fascicle that is responsible for this bump here after this um, strain. As we have seen, we need to try to find the injury in this place here, and on the medial side, as we saw at the level of the arthroscopy, and it was assessed as in an ultrasound, and we found that we can see some things that it's not all the ultrasounds find are fine for that, but now we are starting to practicing with this, and the disorder also mentioned that the functional limitations. So we're going to end with this comment. This we all know since the 70s how popular it was the mechanical ankle instability versus the functional ankle stability. In my case, I'm a physiotherapist, and it was never clear from me the meaning of ankle instability. But now we need to see how we introduce the micro instability within the scheme. So it is something that so what we did some times ago is just to check what functional instability meant. And I was working, was just reading what Jay Hertel was doing, and he was already speaking about these patients that they've got repetition strain, that you see that the ankle is not unstable, but there is something strange in there. And obviously, this comes after the three papers that were published some years ago by a British researcher. We don't know exactly what happens to these patients who go to this strain. They don't have a pain, but normally they do not make sport, but they want to do sport. They have a repetition strain. And so what we're considering now is that maybe all these patients will really have it was subperifasticular injury that was not easy to diagnose as it is right now because this paper comes from the 60s. And so year after year, we can see the evolution of these ankle strains that normally it's an evolution towards something much more complex, as something you can see in this scheme that is recently published. So when we speak about mechanical mechanical stability or functional stability, we speak about insufficiency, and it has a derivation of ankle instability. And some of these models do not include the fact that the superior fasciculum it is a separate joint part of the body. And most of these articles, most of the papers, as you know, they are widely published and they are open published. And now we are about to publish a new number of this, a new issue of this magazine, And we're going to speak about the ankle sprain and the dominance effect. We're going to explain how when you've got this kind of injuries, in particular one that is going to be linked to cartilage, that can evolve or not towards and something more serious. It's like domino pieces that they go falling down, and they can be translated into other injuries, so to provoke instability. And the topic is much more complex than what you ever thought. So in order to finish, if just to give you something to take home, you should understand that supraphysical is an intra-articular structure, and the partial complex structure will end up on a microinstability that is really necessary to start diagnosing this pseudophysical individually. And now I'm going to finish. Let me tell you that next year we're going to hold a MIFAS Congress, that is the International Congress of Minimally Invasive Surgery. I'll be here in this conference, and so I kindly invite you if you want to come to Kamasi. Now I give the floor back to Dr. Nagalis. Thanks a lot for your kind attention. Thanks, Miggy. Thank you very much, Miggy. So now it is clear. Now my job is getting dirty, maybe. Now we need to take it to the consultation and what we have to do in the consultation. And it helps me a lot now just to think what we can improve. But once in that point, after this explanation, I would like Dr. Pasquale or Vicky, I would like to ask Dr. Pasquale and Dr. Ramos to tell us which kind of tests you do in your consultation when you have a suspicion, when you're suspicious about instability. If you do that for anamnesis, or if you always ask about previous ankle strains to all the patients, and how do you manage these kind of patients?
Well, good morning, everyone. Yeah, uh, we need to consider what happened with injury, how long it's been there. Then we need to do some radiology in charge and load fluoroscopy with stress tests. And this is very interesting because what we read up to now it was to have X-rays, but the fluoroscopy, uh, according to Dr. Ramos, is not useful. But would you say that stress fluoroscopy is better than stress X-ray? Yep, exactly. Mickey was saying that considering micro instability, the talus bone has been displaced, or with the fluoroscopy, apart from doing the Taller test, and we can do it together with the fluoroscopy, and we can see the displacement anterior-posterior of the talus bone. Apart from that, with the ultrasound, which might be a little more difficult because it requires two people to see the displacement of the talofibular area. However, I like to do the single leg hop test and sideway hop test, which is basically asking the patient to jump on one of his foot as hard as he can, going forward with the healthy foot, and then try again with the injured foot, and then moving on one side on one of his legs, but moving to one side. The idea is to get the joint to go to the limit. If there's a damage, he won't be able to perform equally with both foot. Then, so what I do, we do the same test in both legs to see how they perform differently. And So I agree with Raul. I don't perform stress X-ray. I don't believe they're useful in these cases because it requires a sedation uh, because sometimes there's pain and for me, in my opinion, the pain completely affects and ruins the test. I think an ultrasound is not easy because it requires two people. You can't do it on your own. However, the ultrasound, the results are always subjective. So, but the Taylor Tild test is in internal rotation when it comes to this instability, micro instability concept, and then also the maneuver described by Dr. Vega with this patient sitting down on his bed with a 30-degree internal rotation and in cases of micro instability, this test hasn't been approved, correct? No, it hasn't. And that's the one I use sometimes. So for me, clinical um, examination is very important. And if there was no previous sprains, but when the patient refers previous sprains, then it's hard to say. I mean, and so the Taylor Tild test, this is the right way of doing it. And so just to remind you how it's performed clinically, and this is the correct image. And regarding image diagnosis, any of this stress, ultrasound stress, do you think it's or in your opinion, and any of you, when you have to perform ultrasounds, what is it that you do when you work together with the ultrasound experts? So do you think it is really useful, the ultrasound? Yes, if the ultrasound expert needs to be also quite expert, but if you see the whole ligament in its whole section, possible tearing at a talus or fibular level, and also the distraction chances in the talofibular complex. Can we stop these? Can we play these tests? So here we have some videos of what we can see in the fluoroscopy, whether it's a asymptomatic or symptomatic foot. We're going to see the asymptomatic for you to see a lateral normal stes with fluoroscopy. And in my experience, this happens pretty often. If you can see, the talus is projecting. It's projected. You can see it comes out, sticks out. And so this, when we have a lateral ligament that is broken, many patients live a normal life. And does this really require a treatment? How do you manage this? And then the line separating conservative management and surgery is very blurry, certainly. So can we define that line a bit more? And to finish with echograph, with ultrasound, we know that it's useful for abnormal displacements of the talus bone, and also the condylateral of the talus is also, when it's displaced, it's also convenient. And what I find interesting, and this is a question for Dr. Dalmau, is seeing how the ligament in plantar flexion and the plantar ankle So with the calcaneus ligament, if you think those tendons sticking out when you have to explore them with the ultrasound, does that make sense? Exploring it with the ultrasound, or we're just wasting our time? Well, what is true is the we can see there's pressure from the peroneus, and this is a distension, ends up in a distension of the calcaneum fibular. And you see how it's pushing to the lateral, the peronean tendons. So it is possible. Well, I think it can be done. We do it actually, but sometimes it's difficult to apply what you read in the literature and apply it and your practice. So we do it, but we're wondering if anatomically it makes sense apart from the exploration examination. The only way to visualize it was with an arthroscopy and seeing the ligaments from inside. But I think that ultrasound would make sense in this concept of micro instability to be evaluated, because the superior ligaments can be seen perfectly, maybe the inferior not so much due to the placement of the fibers. But sometimes it can also be seen pretty well. So it would, I think this would help to improve the diagnosis within our practice. Okay, one thing, well, I really wanted to get an answer to this question. And we've read, there's lots of literature talking about this anterior drawer test of the knee maneuvers. And this maneuver requires two people. One needs to manage the ultrasound machine and the other one needs to perform the maneuver. So really, in theory, it looks good, but in reality, I think it is difficult to perform. I don't know, what is your opinion, if you are able to do it or never. Have you ever considered doing it at least? Yes. Of course, as you know, we do. We do it. Maybe if you wanted to do it on your own, you could, like Javier was saying, Dr. Vega's technique, you could collaborate with the patient and ask the patient to bend his knee. And so if you can do it with the ultrasound and you can see it, maybe you can see how many millimeters displacement, because it's supposed to be a relationship between the degree of and the millimeters of separation. So what do you think in stress radiography or stress X-ray and stress ultrasound? Well, I think we need to also work with the patient's sensations. Um, of course, all of these scientific papers, they help us understand, they help us classify to then consider one or another treatment. However, it's many times, most of the times is the patient referring, I'm not able to jump as I did before, I'm not able to kick the ball like I used to. So it helps understanding the concept of micro instability, trying to classify, trying to say, um, eh, try and measure the millimeters of displacement, or trying to work with the ultrasound. This is pretty relative. This is the important thing here, is that the patient saying, I don't know what's going on, I don't know what I have, but after this injury, I'm not able to perform like I used to. We can talk about micro sprains if you like. There's no uncured sprain. And the patient is referring, they cannot have their normal life with the intensity that they used to. And it classic, it's really good, but I think what we really need should matter to us is listen to the patient and see what we can do. And we'll see different options. But like Mickey was saying, most likely one of the main problems is that the talofibular ligament, the anterior one, is not gonna work as they cruciate, and we are uh, we have to do something with that ligament. There's no other option, and maybe surgery is the way to do it. Well, you have it quite pretty clear. Um, okay, let's see if I can challenge you with the other cases down the line. Um, so, what was Bernal was saying, the main problem with this the theory of its micro instability from the clinical point of view, it's an act of faith. There is no evidence. You're trying to see it with the ultrasound, the X-ray. There's no test that can tell you in an objective way that this is what the patient has. Um, so I don't perform any arthroscopies, and so when I bump into these type of patients and I perform all the tests, and then um, I wonder if the ligament is broken, is ruptured or not. So there's no objective test uh, that we can do in our practice, and that 100% can tell you if there is a micro instability in that patient. Yes, you are right. And the thing is, when you bump into patients that come from referred by other colleague, and you see that the repairings of the structures end up fixing the problem, so that's when you realize that this has worked, and you do repairings or in whatever way to give tension and new function to this lateral ligament complex. A patient without extreme symptoms, but you actually manage to heal and cure the patient. You realize that you don't need all these many tests in order to believe if the patient has this or that. I understand that there has to be a protocol. We need to have tests that are viable and reproducible. Also, in order to be able to explain to the patient that this or that is ruptured, or the distance of displacement is whatever millimeters. But nowadays, I think that this is too clinical. Uh, so just to I would like to add, I agree with both of you, and this is this act of faith that we ask from the practitioners. And Bernat knows the slap injury, and because his father, and this was an invisible injury for many years because there was no way to objectively find and define the injury. And that's when we realized anatomy is the cornerstone to start walking towards a diagnosis. We didn't know if there was a micro instability of the hip, and uh, eventually we find ourselves knowing there is something there. We know that from the clinical point of view, we're not giving an answer to the patient. Many times the family doctor, the GP doctor, they just dismiss the patient without helping much, and then they come to us for answers. So, but now the question is, how can we diagnose this? We can also ask for MRIs and um, to confirm previous diagnostics. And when it comes to ligament injuries, uh, do you see any limitations in the MRI? When it comes to the ligament injuries of the knee, well, nowadays the ultrasound is amongst the functional tests is becoming more and more popular. And Alvaro was saying, talking about the arthroecography to see any liquid leak, fluid leak. So many times the problem is that the anterior talofibular ligament and the ATFL, you can see this dorsal insertion. Sometimes the ligament is not ruptured as such. You can imagine this as a line where you hang your clothes out to dry, and two things can happen if you put too much weight. Either the line breaks, the thread breaks, or you just tear maybe the screw in the wall hanging where it's hanging. It just tore apart, and this is what basically what can happen with the ligament, because the ligament, we can see the ligament, the entire ligament. If we know that what we see is that the ligament has fallen down, and yes, and it's now together with the in touch with the complex and the fibers under. But if it was more of an acute injury, we could see the edema or maybe fibrosis in the area. However, it's not a dynamic one. This, in different discussions we've had, this does not only happen in the ankle, it happens somewhere else in our body. You can see this also happening in the knee. Yes, I was working with my father with all these injuries of the external lateral ligament. We realized that many patients came to have an arthroscopy, and you wonder, wow, same thing. Here, what happens is that different injuries are adding up, are piling up due to this, but the main thing, it's the instability, and then we're adding layers or pathologies, and we had a game, and we had a well, with little game with Thomas. Let's say someone has an accident and breaks the meniscus, but there's young people with degenerative rupture of the meniscus, and we were betting, is the cruciate broken or not? And I would say that 90% of the cases, that's what happens. There is a de-insertion of the tibial, and then it's close to the anterior cruciate is touching the posterior cruciate, and it's pretty much the same. Dr. Ramos, or any of you, can you tell us why there is an impingement when we have some stability? What is the talus bone doing there? Is it tilting? It's moving front or to the front area? But well, in case of a lateral injury, the talus bone, it's tilting forward, and it starts being in touch. The talus is in touch with the tibia. So the periosteo, it starts deforming, and we are seeing an osteophytosis. And that impingement, it's bone impingement, and sometimes the anterolateral impingement, it's of a soft tissue, is like a synovitis. So you can have this internal rotation, and that can develop injuries in your foot, in the internal side of the foot. Wow. So this we'll talk about different hats and different of those of you who work with ortheses, plantar orthesis, might find it useful to discuss later. But if the talus bone will rotate internally, but anyway, we will talk about the treatments later on. We're now back to diagnosis. Anyways, so infiltrations, is this something that you would, in case of impingement, would you do an infiltration? Impingement, no. I no infiltration. If I have a clear diagnostics or diagnosis, I don't. No, for me, it's not. Um, we're talking about impingement or micro instability. Can we have an impingement without instability? No, I don't think so. It is in my humble opinion, and yeah, that's well, when surgeons they repair the the osteochondral injury, it didn't happen just from sitting down, and so this is something. There's probably an impingement, and it's usually the talus is pressing the tibia. So most likely there might be an impingement case without a ligament injury, but I think many times when there is an impingement, there is something there, a hidden injury with the ligament. Well, infiltration is something I would consider not as a therapeutic treatment, but as I don't know, so maybe a bit of infiltration in the area of impingement in the soft tissue, lateral soft tissue, just to put a bit of anesthetics that we can do ultra guided. And we have the symptomatology because there's an impingement of the tissue. And yes, we can have micro perforation. There's so many different therapies, but I want people to understand what we're doing. If you do infiltrations, we have here a research from 2017. They reported good results with perforations. I don't know how sustainable this is in the long run, and if we cannot, if a patient can't have surgery, we need to manage pain. We need to consider a mid to long term management. Is there anything else you would like to add? Oh, I think the last thing, and I probably have no evidence, but from the clinical point of view, it might work, and this is plasma might work. And when it comes to regenerative therapy, we talk about stem cells. I bumped into a surgeon in Barcelona who was culturing stem cells, and they were saying that the results in soft tissue mainly are quite hopeful, and we still have a problem with the ligament being torn from its original place, and this might end up in a fibrosis around the injury, and maybe the patient can see some improvement, but anything around any treatment around the injury that is not actually correcting the injury, the patient will see an improvement, but the injury will still be there. Well, when it comes to conservative treatment in acute entorsis, um, in different phases. No, they usually in the first phase of the first 10 days when they have some swollen, and then when they have their three different phases, the proliferation, and then the last. So we need to in the inflammatory phase. We need to mobilize and then apply the RIC or the police or any other algorithm, and so and then in the second phase, the proliferation phase, there are ortheses that can help stabilizing. In any case, if this is properly managed, in this case, we can reduce about 20 to 60% the consequences of chronic instability. So the treatment that it's more prevalent, the conservative treatment that it's more popular in the practice, I think, can we agree on that sport and exercise to stabilize the ankle, it's critical. But from our point of view and what we do, what do you think of the plantar pads or plantar orthesis? Would you do it at the beginning? Would you combine it with tapping? And when would you start using this external orthesis? Well, wow, we've just opened the Pandora's box here. So regarding plantar orthesis, I use them when the patient is in barrow. The patient has a chronic instability, the axis is slightly deviated, and so there is a pronation. The idea is to get the pronation. So before this starting talking about micro instability, we were talking about functional instability, and we didn't understand that the ligament was broken. We just knew that was a mechanical instability and not functional. So there's some research, one specifically that caught my attention in 22, and so the reaction time of the peronees was not, they were not working properly, and the peronees took a while to respond. So what he proposed was using to invert the foot. And yeah, he was getting very good results with this heel or the wedges for. And I had a sprained ankle when I was 13, and every year I have a different injury. If I'm running, that's okay, but if I go hiking, I always come back with a sprain. So you need to so I need to I my foot is flat, so my foot is it's pronated really, and I wear insoles, and uh, there was a time in my life when I didn't sprain ankle um, with these wedges. So what I do is I prone patients who are supinator. We have supinator foot, and sometimes I wonder, well, they could improve the peroneal reaction, and it did work for me.
So it's going to improve. And so it's not an insult. It, in fact, what we can see there is a last. And so from the historical point of view, we try to put something that will just push the talus bone. And so we try to do that. Maybe we can understand this. But in order to assess that, Raul uses some tests that I think that's quite easy to put in practice. But I also try to put others that with one ankle and the other, we try to arrive to all the points of this star. And they try to do it with or without some stuff inside. With uh, you know that we have to make different all the work that we have to do here, and so it is important. So we need to because when we introduce this bedpan, that this helps a lot. So external orifices, it's something quite useful for this severe and chronic. And so it is something that we have to show. But anyway, I would like to ask you about two or three conflicts that I've got with the insoles. The first one is how do you take the use of the insoles? So because it's true that with one kind of food you will do the other thing. So if you decide to introduce plantar support, or if you see a positive anterior drawer, and so which mode would that take? A neutral, maybe, or not? So how would you do that? Would you do supination with a little bit of the talus one, so to avoid the falling down of the talus bone? I try not to make a big correction. I just want stability at subtalum bone. And in the case of a calf shortening, we speak about something light, not severe. So in this case, you do this test, it is positive, and what you do there. And so anyway, it is difficult. So if we wanted to introduce this wet heat or something so to make it easier, so it can be so it's gonna help this hint food. So it's maybe could be there, okay, or so. But I prefer the rear part to be down, the heel to be down, maybe. So would you put a lateral control, like a pronation weight heel, a pronator weight heel? No, I would just change it. So this cannot be back. If it's talking about a normal food, yeah. So I think it's something that you will try to do. Something easy, so something that's well known. And also, you know, if the patient is developing an impingement about the orifices, if he wants to pronate, you need to check you need the pressure center to be on one side. So you need to put this pressure center on one side according to the location of of this angle. So we know that it goes in one direction or the other, and so the biggest point is this on the forefoot on the midfoot. It is exactly there where it is much more efficient. But the insole is more efficient for the pronator if he wants to pronate. If he wants to pronate, my advice is change it on this side, and in the midfoot, maybe we should increase the arc, and into the forefoot, it is where you have to concentrate the strength. And so the pressure center will be just placed laterally, and it will come to another place, and it will go to pronation. But the only mechanism of the insole is its strength. It's from down up, and the bilateral strength. So it is not something done by the insole itself. But for me, the effect is much more limited, and the ferula works even better because you have a position over the ankle. I had an instability case, but I was very running out of time and not to use that. The patient that was using within symptomatology, and the food was normal. But continuing with this concept, we're talking about insoles with little support, but everything what we tend to do is to stabilize the foot, and we're not very clear if it needs to do pronation or not. But what do you see in a patient? What do you have to see in a patient when you're thinking about surgery or not? Much more conservative treatment, and you try to do examination or pronation to try to intervene to make an surgery on a patient. So when it affects his or her quality of life, you could have a big injury, but maybe a patient doesn't need this articulation for normal daily activities. So, for instance, in the papers that we have, at the end of the day, it is that if the patient has pain, we act. If not, we don't. Because I kindly invite you to do that in the consultations, because sometimes you will see big instabilities. It's quite frequent every day in the consultation. If you apply what it is in the literature, you will just send a lot of patients to the surgery room. And here we have the preventive uh, podiatry medicine. They want us to buy toys, but we know that microinstability or instability, they will develop future problems. But we start thinking now some treatments, because maybe this way you will stop the development of your injury or so. No, I don't think it is the way. It's not logical. I do agree with Raul that we just need to think about that. Uh, Always when the patient asks for that, and this patient says, I did a physiotherapy, I use my insoles, and I'm tired of not doing normal life. I know there are some instability factors like shortening and peroneal rupture and so on, but I don't want to focus on that. I want Bernard to tell us which kinds of surgery options do we have. How do you classify these different surgery options? And what is the meaning of an anatomical or not anatomical reparation? So, anatomical reparations, it is to try to reconstruct, according to this wonderful literature from Mickey and the rest. We know the incision and anatomical pieces, and so trying to do direct reparations onto sutures or plastia substitution, as it can be with a cross ligament, and non-anatomical is what was classically used to use as closed structures, so to give a new stability to the ankle. You can use a peroneum, so to place the splint and onto the fibula and try to put it on the ankle. So we had a bad result at the beginning because normally the ankle is much rigid. So these are no anatomical. They're talking about Kasten anatomy. And so people say, ankle is fine. Yes, yes, ankle is fine because you cannot move it. So it wasn't that clear if at the end of the day that was positive or not. But now we know, and it is, has been published, that anatomical reparations, so trying to suture or to correct or substitute, but using anatomical insertion points. So your preference is the reconstruction. So if we put some ligament, so if it's broken, you do a ligament plasty and you do anatomic reparation. But instead of using perineum, you use another structure to repair the area. We normally use some tissues from a tissues bank, from ultra frozen um, corpse or any other chronic injury. So it is easy when you have to do a plasty of both. And what about if the ligament is stressed? So that is most of the cases, in fact. And so what we normally decide is to do a re-strengthening with a reinsertion of these superficial fibers. Then normally they all falling down, and you can see the anterior side of the fibula, and you, that is where the talus bones should be. And so we try to check this footprint and this insertion site, and we do a couple of suture stitches. So we do a perforation, and the implant will just take the stitches, the suture, and will just bring the ligament closer. And then fibrosis will take place, and everything can be together because the ligament is not broken, it's simply not in the right place. And Javi, can you explain to how you do it, and in your experience and with the literature, if you think that Boston makes a sense so far of is not being less used maybe, or if they're going to use it to work all the time. But Boston is an anatomical reparation of the lateral ligament. I think that he published in 1940 his best his first paper in good data modification. And so we're working with the capsule, and within an open surgery, we in all the capsule we do and the pan over space make a reinforcement of this structure. So we do something like a jacket in there. It is also done in jacket to put a mesh there. And so Brosnan only used this capsule area and could use the extensor retinacle. And Broston cool is when you are in the deep fascia, all this tissue that used to be hypertrophia, and you break it and you suture just one on the other. And there is another modification from Elie Tournay, something by Dr. Tournay. What he does is to anchor the fibula and the anterior side of the fibula. But it is true that the arthroscopic way still seems to have a big room for improvement. Yeah, and also I think it also depends not just on the operation but on the diagnosis. Because if we see that when we have to do is an arthroscopy to see what is going on, so if you have to do it, maybe you can make a profit just to continue with the surgery and to make something better for the patient. And so, because then at the end of the day, diagnosis will give us the idea about how to um, uh, approach this kind of things. So, if we want to treat this kind of injuries, maybe we need to train ourselves on that and to have some specific training, or we can just send that to traumatology. But we need to understand what is better for the patient. obviously, according to diagnosis. Yes, but what I wanted to say is, according to my limited experience, only three cases, they were mechanical instability, not micro instability. So I do this reparation when there is a really mechanical instability. And now I'm going to propose a small case, a 56 years old man, and comes with this, what you can see here in the screen. On the left foot, that is the foot with positive MRI, and that is all. You can see that only an MRI was done. This is the radiography, the X-ray. Those are the pictures from the patient. You see the middle arc. The heel, I don't see very valgus. What valgus sensation is on the mid foot. When I ask him to move the foot because a little bit fat, and he and also through the tendinopathy cannot do it. I'm sorry with the video, but the problem is what really happens that he's about to fall down. Look at this X-ray. Bernie, can you tell us what you see in this X-ray image? If you look at the subtalus bone, it's not pronate. It's also in posterior tibia. You mean here, right? For me, it's not a very pronated foot, not an especially pronated foot, but it is there is an interiorization of. Do you see the space in the rear side of the tibia? It is the talus bone is moved, and you see the median migration of the uh, talus bone head with a lack of coverage, maybe 30% of the head. You mean right here? Yes. This in the ankle bone. You mean here? Yes. If I see this projection, maybe I can think about enlarging the cord, but it's not a plane. It's not valgus. Something? Anything else to add? So we decided to make these tests, and as you can see, we cannot. So sometimes we should do some stress radiographies, stress X-rays. So if we are going to have an anterior drawer, it's really clear. So and tertiary talar is huge. It seems as the talus bone is going to fall down. So what would you propose to do here? I come back to the X-ray. You've got okay. That is the situation you have. So I've considered that tendinopathy is a consequence. So we should assess the integrity of the ligaments, and then we can decide to either strengthen them or substitute them, and joints should be in its place. That should be the beginning, and then we should start with the rehabilitation, readaptation work, and normally this diagnosis will improve. But the problem is an ankle instability. That is what we have to repair. So, in surgically speaking, so we think about repairing the ankle. Initially, not. I would just just to reposition the talus bone and so on. Do you think arthrodesis could be good here? this implantation at the beginning of, because you see the talus bone like this, and if there is instability, an ankle instability, maybe you can think about orthodoxy maybe in this area. Yes, but it is a clear imbalance in between the two X-rays. Uh, I think it is like there are someone changed maybe or edited this uh, this X-ray because so there's something strange that, but I think this X-ray can be false. Due to the position of the first metatarsal, I wouldn't just give a lot of importance to this X-ray. And to see that the astragal capsule is not in the right place. So if we just check the lateral one, what you can see, do you think that the talgus is projected towards the front? Yes, but where is the pain? The pain is posterior tibial. So outside, do you see anything? I would just work on the posterior tibial and do a pronation on the foot. So it is clear here. So the axis is deviated. That is clear. So there is not lateral phantoms. So I would try to adjust the posterior tibial. That is what I would do. I would just take away the pain, but the patient has the pain. But I would do that with insoles, not surgically. In this case, I wouldn't just send the patient to surgery. With having a look to this instability, I don't consider surgery will be not the case. I will try it, conservative treatment. Michael, you said that when we strengthen, talking about the ligament, so this posterior fibular. And I would like to say yes now to close on this table, this round table. So I would like you just to put an end. I would like you to tell us what is this pathology about, how it is posterior ankle pathology, and if you consider if it is going to affect also the drawer, because we know that normally it is related, even more with paratenum or any other kind of structures. So can you explain that slowly, or do you want to use your presentation? You've got 5 minutes. So we started 10 minutes later, so don't worry. Yes, at 10, 5 minutes, that can be okay. So I just want to remind that what we've got from neurological point of view, lateral side, and we see this horizontal cut of this posterior uh, area. We see the calcaneus, we see the images. We're going to have this deep posterior side with the fingers, sorry, with the toes, and and the fibula. So about what Pedro said, we're going to have this posterior fibular ligament that is going to be inserted into the lateral mallular fossa, and is going to have a different aspect. If we see, as you can see on the right, with a normal talus bone, or if we are going to have an os trigonum, as you can see here on the left, but it is something accessory, and so we're going to launch some fibers to stabilize the movement of this tendon of this os trigonum. Sorry. In the case we need to do a resection of this os trigonum that you can see here with the different ligaments. So what your surgeon is going to do will be just to dry these adherences. We've got here these fibers, and that's will be the case after the resection. This os trigonum, as I said, it's an ossiculum, as you can see here in this, you can see synchondrosis, this bone mistake, and other variants that we have to bear in mind in a posterior impingement will be this theater process, that is the hypertrophia, or even this Shepherd fracture. And so on, that we can think if we've got that's really always the case of a sportmen and women. And in this picture, what we can see, this tunnel that we have here, and we see the post medium tuberculum, and there the hallucis flexor, the flexor hallucis longus will be there. You see here two examples, to, of two specimens at the same level. We see a big hypertrophy of a muscle here, and on the right we've got a shorter, a minor tendon. We did that with an MRI, talking about these variations. We see here an endoscopy, and how the light comes easily. But what happens when the patient has these low line muscle belly or hypertrophy, so it's difficult to enter in the tunnel. And also there are some accessory muscles that will be seen as a double tendon of this long flexor. And if we add an osteogomon or more things, then we have more problems even. And you can see also this picture. And the intermalleolar ligament, you can see here these fibers. These fibers are here we can see the intermalleolar ligament. It is not well known. We spoke before, we said it could be a ligament that very constant or not. No, nowadays it is clear it is constant, but the morphology varies from one person to the other. And in this ligament, we need to understand the normal physiology of the ankle. When we move our ankle from dorsal flexion to plantar flexion, you see how it folds itself and it is trapped into the postlateral tuberculum and the rear side of the tibia, as we can see here. Maybe we can see the video, and you can see how it goes back itself, and it says another structure that is going to be damaged if we have a variation of this tuberculum, and it was described as posterior soft tissue impeachment, and it is something also related to ballet ballerines. And here I wanted to just to mention the posterior tibiofibular ligament, because it is the next structure we can identify. Just to understand the anatomy, we need to have a look to this plantar view, where we see superficial fascicle that transverse ligament, also called deep fascicle, that works as an labrum that just is covering the posterior side of this ankle. And also in this picture, you can see this structure here that is the same, no veer fringe. That is a structure that buffers the tibia and fibula when we do the plantar flexion. So um, it is quite dynamic. It can be responsible for some mosaic impeachment, and we can see the left on the left side is a normal picture, and on the right side, you see this syndesmotic impeachment, so with this hypertrophy, and it's something that we should bear in mind. And now, finishing with this ligament, Ruviera and Canella ligament, it's a very unknown one. It is was called something like the forgotten ligament. So it is a necrosis in this fascia you can see here. It is separating all the compartments, and the deep side. We can see here how the calcaneum tendon has been rewrite, recession. And here we can see this strengthening of fascia, and how this fibulo, talocalcaneal ligament, and how it can be the cause of fibrosis or and many other complex injuries. And we here this ankle fracture, and we can see here how it can provoke a movement or replacement of the rotation center. Now to speak about differential diagnosis, we have got some pictures here about the calcaneal tendon or the Achilles tendon, how it is separated by this retrocalcaneus burst, and in this Hacklund disease, as you can see here, and you can see this space after our section, we can see how this posterior side of the calcaneum is also full of cartilage, so to make it softer, and how this calcaneum tendon suffers a rotation of its fibers on a normal side. It is uh, it is a mechanism to improve the strength on this ligament, but also this rotation provokes that 4 or 5 centimeters before this section, it is the only place of this tendon that is irrigated by the fibular artery that is smaller than the tibial one, and so it is a vascular area, and it testifies why we've got overuse tendon conditions. About some plantaris tendon variations, we have some variations, as you know, and one pathology can provoke others in the rest of the tendons. Here we've got the tendinopathies origins. We see here some structures that I only saw in your presentation, Pedro, like these small fibers, this the fibula the tibia calcareum, and so on. And just the message to take home, something we should consider is just posterior lateral talar tubercle, the synovial impeachment, and calcaneal tendon pathology. And that's could be all.
Well, this is ending by opening the Pandora's box, because now we're left with many questions, anyways. But just to try and wrap it up, one of the most frequent pathologies that makes sense treating with infiltrations in our practice, and this is just to finish, we talk about instabilities and what happens in the posterior area and ligaments and everything. But I'd like to talk about trigger Alex. If you could give us 3 pieces of advice to be able to treat it, and if you think that infiltrations make sense in this case, because we were considering removing the trigonum with surgery, but with regards to the clinical management, what would you suggest? Well, I think I don't know if they have been described the flexor ossiculus. Also, the lower belly, the muscle insertion of the lower muscle. What happens is that the muscle is going to insert in the posterior side of uh, the end of the talus. So that's why the patient will have this sense, this feeling that the dead, he cannot move the toe. So were you familiar with this test? Because this was recommended to me by Nikki, and it basically, we can see a normal range of movement. Maybe we can see it better in the video, and I think it makes all the sense, and it can be reproduced. So basically what we're going to do, if the video cannot be seen, we're going to explain it. We can see the normal movement range of the first metatarso phalangeal joint. And we can do this Silvertio test, as we've seen. But if we do this dorsal flexion forced, allowing pronation of the foot, and you pull the toe, and it can't move, it is blocked, and it can they can refer pain in this area. Do you think this test makes sense to try and explore this area? And this can be seen very well with an ultrasound, and especially when there's some swelling in the area. And I think it would make all the sense to to apply infiltrations. But if you have large trigonums, you can do it. But some patients might have a certain instability, and all these many factors together. But in some cases, we're talking about insoles when it's not so clear, and surgery in some cases as well. But before we have any symptoms, we cannot make a decision towards the future to see which patient's going to need more or not, because sometimes tests come positive. And I don't know, you see loads of broken fibulas, and then nothing happens, and then it can be a similar thing with this case. Anyway, Mikkel, thank you for your anatomy presentations. We are very lucky to be able to have you here. Thank you all, four of you, for being here, and I'll see you around. You are not getting rid of me just yet. So thank you very much. Our following panel, it's entitled Diabetic Foot, and it will be moderated by Dr. Almudena Cecilia Mattia and the following presenters: Dr. Gabriel Rivera, Dr. Jordi Samaniego, Dr. Juan Pedro Sanchez Rios, Dr. Jose Luis Lázaro Martinez, Dr. Monica Rodriguez. Good morning, everybody. It's great to be here sharing with my colleagues. Some of us are friends, and we could be here or in the restaurant having fun somewhere. And we're going to wait for 5 more minutes or 4 more minutes until 10 past. And before we start, so can we give some time for the people who are having coffee? Okay, so 4 more minutes and we're going to start. So before we start with the presentations, let me introduce you to my colleagues. And Jose Luis is our mentor of most of us sitting here in this panel. We work as a team and we support each other. And when it comes to fighting this terrible disease, we're starting with our first panelist is Dr. Gabriel Rivera San Martin, who is going to talk to us about the comorbidities of diabetic food. Then we will be continuing hearing from Jordi Samaniego from the Vall d'Hebron Hospital, and he's also part of the working team of the Spanish Diabetic Society, and he's going to talk about the assessment of this disease. Then we'll hear from Juan Pedro Sanchez Rios, who is the manager of the surgery department of the hospital in Madrid, and he's going to talk about when to act and what to do when it comes to the diabetes. Then we'll hear from Professor Jose Luis Lázaro, and his CV is endless. But he is the professor of the University Complutense University in Madrid. He's a benchmark in podiatry, and he's been included recently in the Stanford University list as one of the most prominent researchers globally, and we're very proud to have such as a colleague. And last but not least, we'll be hearing from Dr. Monica Rodriguez Valiente. She's a master's degree in clinical investigation, and she has a bachelor in nursing and a bachelor in podiatry. And she collaborates with the IMD Osaka, and Dr. Lazaro will also talk to us about the infection treatment. And without further ado, let's start with Dr. Gabriel Rivera San Martin, who will talk to us regarding holistic considerations when it comes to patients with diabetes. Thank you very much, and it's a pleasure to have to be here. Thank you so much for your presentation, and let's talk about diabetic foot. And I am in charge of talking about the least podiatric aspect, which is what is related to internal medicine for these patients. And I'm going to tell you what I would have loved to learn when I arrived in the unit at this hospital that I'm working now to work in the internal medicine department. So I'll give you a crash course. So we're all talking about diabetic foot, how important it is, how spread out diabetes is, and how hard it is for them when they have complications, they have amputations, mortality. And why is that? Because I like saying that diabetic foot is not an ulceration, it's more than that. The ulcer is just the tip of the iceberg. However, what we should be digging into is what is not seen. So what's underneath the water. So what is this diabetic foot syndrome? It can be defined as a constellation of disease processes that will affect the patient and will have an impact in immune system, in cardiovascular, endocrine, immunologic, in different aspects. Unfortunately, the patient will not understand and right from the beginning, because we think diabetes can be treated just with a pill, and we are not familiar, or patients are not familiar with the complications associated. Now let's talk about a list of comorbidities that I'm sure you're familiar with, and we're going to go through them very quickly. And what I would like to do is the kidney disease is highly associated with diabetes, and both together are an important factor of risk factor for amputation of the lower limb. If we include an ischemia, this will make it very difficult, and we get poor results with a revascularizations, because their arteries will be more stiff, and it will be very difficult to open them up and increase irrigation or improve irrigation. So this is something that we need to be familiar with. And it's also important to highlight that we have ulcerations in diabetic foot that will take a while to be spotted, and will most likely end up in chronic swelling. And so if we have a kidney disease, this ulceration, it will help this kidney disease to progress, move forward, and this might end up in a failure kidney. So it's not only important to heal this ulceration to allow the patient to walk. There's more reason. There's more than that. It goes beyond than that. And then another famous comorbidity, it's high blood pressure, will have a negative impact in the evolution of the ulceration because it will increase microvascular complication and different mechanisms like artery stiffness, plate formation, and this will also have an impact in kidney function. So it's important that high blood pressure being under control, it's paramount for many doctors, for many patients to reduce the vascular comorbidities at least. So if we use a very aggressive treatment for high blood pressure to improve the situation of the patients, we will see a diminishment of tisular perfusion, and this will worsen the symptoms of the chronic limb ischemia. So it will help us with something, but will complicate it in a different way. And this is something that we need to add. Other factors, dyslipidemia. We know it is a risk factor for arteriosclerosis, and the levels of HDL and LDL, and this is a predictor of limb amputation. And so high HDL levels will most likely, or they are a predictor of amputation. We all know how to treat this dyslipidemia. We know that statins are good with diminishing this risk of amputation, and sometimes it is prescribed to other types of patients with vascular problems. So statins, the use of statins is also related, all in all, with the diminishing of vascular cardiovascular diseases. So cardiovascular diseases, we know that those patients with diabetic foot ulceration might die or have a higher risk of mortality, and let's say 5 years after the ulceration. So as soon as this ulceration appears, I need to start counting the time, setting a timer, and I have 5 years before we can see some other vascular events. And we're not just talking about cardiac arrest, but we have also it's also associated with low healing rates of ulceration. We will also have tissue hypoxia, we have edemas, we have also an increase of humidity, and this might end up in higher risk of infection. There's another risk factor. It's the immune system, because our patients are immunodepressed just for the sake of being diabetic, and they're more likely to suffer from infections at all levels, from the foot and soft tissues, the respiratory tractor. They might develop pneumonia, urine infection, and so it is very common. We have this list of comorbidities are very well known, but there are other also important: obesity, and obese patients, according to research, they have fewer risk of developing complications because there's alteration of the plantar fat. Also, patients, as you know, there might be other injuries associated with the increase of ulcers. ulcerations, tobacco, tabacism. It's also associated with not a good state of it. It affects the tissues. So bit by bit, we're adding this to the list and all the factors, risk factors, and let's see what we can do. And what has been a research by the major showing the major adverse limb events, and they established a relationship between a good diabetic control with the probability of those adverse events. If for those patients with the HbA1c over 10%, they have a higher risk of experiencing this major adverse limb events, and this is something that we need to take into account. All these predictors will help us and will give us some suggestion. The first one, control of hemoglobin under always just under 7%, because it reduces the risk of major adverse limb events. And sometimes we make it on time and sometimes we don't. And which is our most complex patient, that it's very likely to end up with an amputated limb. It is unfortunately a patient with a severe infection, acute infection with the chronic limb ischemia, and it has also chronic disease, and if he's in dialysis, that is the most difficult patient profile, and it's most likely to lose one leg, and that is not the end. Unfortunately, these type of patients end up dying. The last predictor I want to talk to you about is the MACE, is the major adverse cardiovascular events. And in this sense, it's important to highlight that patients will suffer from cardiac arrests, cardiovascular events. They sometimes even die. And so if you see the picture, you see how the ulcer will make the patient likely to develop infection and oxidate the plate, and will have cardiovascular events being developed as a result of this. So this represents 44%, over 44% of the in inpatients complications with diabetic foot ulceration, and we know that sometimes it develops really fast, and in 10 days after the patient is admitted to hospital, it is super fast and it develops extremely fast, and sometimes the patient is starting to recover. That's when then we have another event, and then our patient goes backwards. So it's important to understand diabetes as a syndrome. This diabetic foot, it is a syndrome. It's not just ulceration, it's more than that, and this can have an impact in different systems: cardiovascular, immune system, kidney system. It is very important, especially at a kidney level. Those comorbidity will have a negative impact in the evolution of the ulceration, but also the ulceration will 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 worsen those comorbidities. And our key is to find out what are the predictors, and like we were saying, 50% of those complications, cardiovascular complications, end up being acute. Thank you very much for sticking to the time. Thank you so much. Our following presentation will be presented by Jordi Samaniego, who will talk about diagnostics in diabetic foot.
You hear me? So thank you very much to the organizers for the kind invitation and to all of you for being here with us. So, today I'm going to speak devote to the evaluation of this disorder, this condition. So the figures are not bad at the worst, as our colleague just said. 85% of amputations are preceded by an ulceration, and every 20 seconds, in somewhere in the world, the patient loses a limb due to diabetes complications. It is true that in a multidisciplinary team, these patients can receive lots of help. So, above all, if we have a look to the international working group, we can have a look to the definition of diabetes food. They want us to leave these euphemisms and to use this book diabetes related food disease that includes one or more of the following in the food of the person with a previous or current diagnosis of diabetes mellitus, so peripheral neuropathy, peripheral neuropathy, infection, ulcers, neuroosteoarthropathy, gangrene, or amputation. And as Gabriel said, food alteration is one of the most serious complications of diabetes and is a cause of reduced quality of life. Something really important about what Dr. Gabriel said, it is important to perform a good anamnesis to detail in this medical history, uh, in the medical history of comorbidities. We can have a history of of lacerations, amputations, socioeconomic status, and risk stratification according to the guidelines. And why is it that important? Because, as Gabriel just said, if we've got a patient who is losing the the sensations, the feelings with amputations or the renal insufficiency failure, we've got a huge risk. When we have a high risk food, what is recommended in the international guidelines is from 1 to 3 amounts. It can be upon demand because normally these patients do not get better but worse. And so it's really important that we understand that the arterial status, for instance, is going to get worse. The next thing that we have to bear in mind is the foot examination. So once we have them a good anamnesis, we need to get to examination. So when socks off, and we need to do examination. We need to use if there is a vascular examination. We need to check the pulse palpation. Apart from that, and we will carry out the ITB or IDB, and we will ask about the clinic. And we're not going to examine the clinic, but with a patient we thought pulsed and with a pain, so we've got an ischemic patient. After that, we need to carry out a sensitive scanning very easily with the diapason, with this tuning fork, and we are going to check the head of the toes and metatarsals. Once we've done it, we can check if we've got an ischemic patient or not with just with this. But we need to carry out with foot inspection. So we can, if we have also some other conditions, skin conditions, so we need to treat all these because if there is a problem like this, so it is something that we have to mention because skin condition is going to be the point of the iceberg, and it can show us a lot of possible complications that will appear in the future. Okay, so anamnesis, uh, clinic, all the history of the patient and so on. So at the end of the day, if I receive a patient with a diabetic foot ulcer, what should I keep in mind? So let's see it. What we have, it is a neuropathic, neuroischemic, or ischemic ulceration. What we cannot do is, as Gabriel said, we cannot have we cannot if we've got an ischemic patient, we cannot just keep that in our consultation because it's going to derive in a complication for the patient, and so maybe the limb and the life is on the risk. So let's determine that we have this kind of neuroischemic user that still have blood, and so we wanted to use that, and we discharge, we treat, and but it's not going on. So something that we can see, and the guidelines is that if it does not work after 4 weeks, so we need to go again. So when we have a ischemic user in the consultation, we are not going to treat it; they're going to derivate. And another thing that the guide says is that we shouldn't debride non-infected ischemic ulcers. So once we know what we have to do, we need to also try to identify what we shouldn't do. Another thing that I would like you to bear in mind is something quite simple to bear in mind. What is if we've got a user with cellulitis around and with so see an erythema of 2 centimeters, so we can have this message. Do we have more? We can have more infection signs, but those will help us to see if it is something severe or is light infection, like in the capsule, the tendons of the bones. So also the guide says that the guidelines say that we need all to speak the same language. So we should use symbol classification and also the modified or for the ischemia, we should use one day with one. It is important that we all speak the same language. The next thing I want you to take home is the clinical suspicious of neurodiabetic arthropathy of Charcot. So if the food is red, it is within inflammation. So it is better if we consider a Charcot condition. So it's better that we have this suspicious on the head, and so not to sub-diagnosticate and to make this differential diagnosis. So we can consider venous thrombosis, podagra, or cellulitis. So we should suspicious that this patient could suffer from a charcot. And then we can see how we can discharge it. So we've got this differential diagnosis, but before all, it's important to have this clinical suspicious of mind because we need to early detect that. And as you can see in this radiography, we can find a very big charcot that will maybe need even a surgery. And we also have the so in the guidelines, we've got a new one. There is a new guidelines for charcot. It's something that you can download and you can read, and it's very clear and very good. Another thing that we should bear in mind is that we need to speak about the active phase or inactive phase. So we needed to we should use this terminology because maybe it can appear again months later, and we can say it is inactive or it is active, and so on. We need to discharge or not. And another important thing that we find in the guidelines that there is no existence, there's no standard for diagnosis, but there is a clear algorithm about what we have to do when we have this species. We've got, for instance, this species of charcot, and so we need to do this radiography. I don't know if it works, Ari. So I clear. radiography. If they're not radiological problems, then we can consider the charcot arthropathy. And if it is clear, the next step will be just to and the MRI. And if there are clear signs of bone to edema or any other things, active treatment, so then we can discharge it or rule it out. So next point, more complex images that are really more sensitive for all the kind of conditions, just to see if there is an infection. And we're going to have the spectral TC or any other uh, uh, mammography, gamma ray. So it is an algorithm that's very easy to apply. And continue with these suggestions from the guidelines. There is a good guidelines for treatment. And here we've got the discharge treatment that can be removal or not, or non-removal. And as you can see, we normally talk about the walker, the knee walker boot that can be removable or non-removable. And then we've got a total contact plaster. When we speak about removable or non-removable device, it is going to be important just to see the kind of patient we've got, if it is a very complex patient. But I'm talking about the level of treatment adherence. So not all have a good adherence. When you tell a patient that we have to put a plaster, normally they don't like, because as a good patient is going to say that no, that he doesn't have any pain, and so we need to negotiate. Another contraindication is the total or partial, because this is gold standard, so we need to just to carry out, uh, so we need to count on a personnel that is staff that is well trained and that knows the technique and the benefit. So we need the evidence of one device or the other, but it is true that we need to immobilize. And about the conclusions, I just went straight to the point because later we won't explain our things. I would like you to take home these four, that's 4 5 pillars. The first one, we need to perform a good anamnesis to be able to to have a good record on the comorbidities in the clinical history. So we need to take care about the treatment, or maybe just to send the patient to another professional. Something really important is to use the risk stratification of the IWGDF and apply the screening frequency. And then we've got the patient identification. We identify the etiology based on the screening, neuropathic and neuroischemic, ischemic, and we should refer in time. Sometimes it would come with infection, con ischemia, like a fluid keep, and also this message of 2 centimeters around the user, sign of infection to be taken into account together with other signs. And we should check other signs like temperature or so, because in this case we're talking about a Pettis infection 4. And so it has to be, uh, that needs to be really clear. And finally, in the presence of swollen red foods with or without deformities, we should suspect about Charcot. And we need to treat that and give a early diagnosis. So that's all. Thank you very much for your kind attention. Thanks a lot, Jordi. And now we give the floor to the next speaker, Dr. Juan Person Ríos, about how to act when diabetes appears and referral criteria.
So, good morning. Thank you very much for inviting me to be part of this panel. It's always great to be here with colleagues. And now it's my turn to talk about something that we work continuously work on. All those of us here have an interest in diabetic foot, the treatment, but we also need to know when we need to stop treating this patient and refer the patient to a different specialist, and to strengthen skills in treatment, but also knowing when to refer. As Gabi was saying, this is a syndrome. As we know, it has high direct and indirect costs to our medical system. It has a high factor of morbidity and associated with amputation. We've gone through this. But anyways, now we know it's a silent um, disease, and we've seen the presence in the past few years of in these patients. We've seen the presence of ischemia that appears from one day to another without presenting any pain or anything. When the trophic injury is the first thing we find, this will delay the diagnosis, so we will be behind the actual illness. It'll be too late. So since 1986, we know that if we follow early detection in primary care and specialized clinics, we will be able to apply a multidisciplinary treatment and with carry out periodic reviews. We'll be able to reduce in about 85% the rate of amputation. And so we know that this foot attack is known as the ictus code, but this is specific for diabetic foot. And they realized that one of the main problems was late referral. Patients ended up or arrived to specialized units once the illness was already highly developed and pretty acute. So if we are able to isolate in that patient 3 items and see we have them under control, it will be a pretty good advance. And Jordi has already explained signs of infection, signs of overload, and ischemic signs as well, signs of ischemia. This is something we need to focus on. Jordi was saying, I'm just repeating what Jordi says, we need to invest and assess in order to prevent an acute diabetic foot, presence of distal pulses, gangrene, hyperkeratosis and helomas, and deformities, swelling, erythema, and sensation of heat and burning. This is after the last update in 2023. These are the symptoms we need to keep track of. We published in 2019 with some of my colleagues in a work group, with some of my colleagues also present here, and we did this circuit of agile referral for diabetic foot ulceration, together with the Spanish Association of Diabetes. We developed this slide, and the idea was to be able to refer these patients who were usually in primary care, and being able to refer them. First thing we need to do is a good assessment, and with the GP doctor, the nurses, and find out about different comorbidities and the clinical background. And we developed this system of traffic lights going from green to red, and this non-complicated diabetic foot ulceration will be no necrosis, absence of necrosis or gangrene, no bone exposure or muscular or tendon exposure. Pulses will be present, and there will be no clinical signs of infection. So then we would recommend the standard treatment, maximum of 2 weeks of follow-up of the treatment, and then assess a 30% reduction of the area of the ulceration. And then if the patient 2 weeks later was responding, then we continue with the re-evaluation of the treatment, and if not, we will refer to the diabetic foot unit. Then the orange in traffic light would be if there is necrosis and the bone or muscle or tendon has been exposed, the lack of pulses and clinical signs of infection, and there's a patient with diabetes in dialysis. So it's stage 5 of hemodialysis or cardiac insufficiency. And in these cases, we were committed to see the patient in a maximum of 4 days, apply the standard treatment, and we would make sure we would visit the patient in 4 days, and then again we would derive to refer. So, and then the last stage was the red light, is gangrene, abscess, fever, or other sepsis signs and indications. So and this, we apply the standard treatment, but then we would urgently send the patient to be admitted at hospital, in hospital. So this fast track, we did measure the effectiveness of this fast track in 5 different countries where we were developing this pathway, and in 2021 we saw that the efficiency was very, very clear, and after this implementation there were less cases being reported, and with the less cases of late referral in comparison to the early referral. So when we studied and went through the data in the different countries, and to see what was the potential areas that we needed to work on, and then thanks to this we were able to improve even more, so different, or polish up different things that yet could be improved in areas in the community or the region of Madrid, and also in other consultations in different cities in Madrid or in Spain. And it also helped us knowing or finding out if we need to have a multidisciplinary team who need to work with the internal medicine, with the infectious disease unit, and different areas of the hospital. I'm sorry, I think I've maybe gone a bit quickly, a bit too fast, but anyways, but I just want to give you some food for you to take away. So 4 key points. It's the need of using this very simple tool, easy to apply, like this fast track. You can visit the Spanish Association of Diabetes. You can download it there, and this is a very useful tool. It allows us to have this holistic management of the patient and the injury. Also, severe acute injuries must be referred to the specialist within the first 24 hours, and then to have systematic reassessments every 2 weeks of the not complicated injuries, and we need to keep an eye on the progress. And that's all from me. Thank you very much for your attention. Thank you very much, Juan Pedro. So now we'll continue with Dr. Jose Luis Lázaro Martinez, who will talk about the approach of infection when it comes to diabetic foot. Thank you.
So, good morning, everybody. First of all, thank you very much to the organizers of this conference for organizing a diabetic food roundtable. I don't know if there is consensus if a podiatrist is going to be included in the public system this way. And it's important. So, and also in Spain, we established a forum. There is a multidisciplinary forum of diabetic food, and also we've got the National Center for Nursing. And in this forum, we took to make the decision that in all the conferences, in all the societies, we could show some of the guidelines for our international working group. I'm going to speak about the infection guidelines. It is one of the most severe complications of diabetic food because it includes the cost, the treatment time, cicatrization, and so on. And also will expose the patient to the risk. And it affects 60% of the patients with an ulceration, and it affects the bone, and the infection will just end up on a ischemia. To approach an infection, we've got international working group. That is a group that every 4 years that edit or produces some guidelines that are and updated with the recommendations based on the evidence. That is very important. Why? Because instead of going just to change the treatment, the only way to change that is to do some treatments based on evidence. So not just every one of us just do whatever we want, but based on what we have. And so in this, the guidelines, we have nine chapters, and one of them is devoted to infection. They are translated, and I think all of what are here, we have been participating in the translation, and you can use that for free. Later on, you will see a QR uh, code. And there are 25 recommendations. The first that is really important is the pace, because the podiatrist has a lot of things to do here. Diagnosis. The infection diagnosis based on a clinical diagnosis that it needs also to be supplemented with the study of biomarkers, with image tests, and so on. Let's see what the guide says. The first important thing is that we should be reminded that this diagnosis, clinical diagnosis, is not very well implemented in many hospitals because some of the patients just come to internal services, the internist just ask for a cultivation for a user. And so we need to check inflammations and clinical science. When there are at least two signs of infection, then the patient can be diagnosed for infection. And the guide we recommend to assess some swollen or inflammatory markers. There are number three, segmentation speed, PCR, and so on. And PCR normally is much more significant, and it is going to change also. And in the case of the sort of um, part, so on. It is very important that the professional is integrated or is included within the analysis protocols because in the lab, because it is going to be vital so for prognosis and to classify severity. Classifying infection severity is the next step after the diagnosis. So there are 3 points. That is the thickness, this perilesional cellulitis extension, and the presence of systemic signs. And based on that, we can classify between severe, mild, or moderate. And as Juan Pedro mentioned before, it's really important to bear in mind that which kind of patient can be treated with a community regime and the attention of which must be referred. These moderate and severe infections somebody will recur refer because they have they put their life under risk. The problem is that in some occasions they are not close to us or we cannot use we're not too close to a diabetic foot unit. And so when they go to the hospital, they only receive the notice of amputation. It's a problem. And but with to keep him or her with a moderate infection or a big infection without surgery, so it is expose the patient to mortality. So and here we need two important actors that will be the surgeon and the doctor. And the guide will also highlight something that is now quite trendy, that is thermography. And it's something that you have seen several times, and for sure in this Congress we are talking about that, about the thermography is now quite advanced, and now we can buy a cameras in Amazon for 25 years, for 25 euros, and you can measure the warmth. And, it is not a diagnosis methodology, something which you should in mind. So it is not understood to be used because there is not evidence enough to support it to. Something that is interesting, some a change that is interesting in this guideline is the culture that we should do with the patient. And it should do a microbiological one. We do not recommend to do that with a metagenomic that was done some years ago, and so not so we should because normally they do not are able to find, let's say, what is the kind of bacteria that we find. It is always important to be reminded that the culture needs to be taken once the injury is clean and debrided, and we should distort the tissue that we should use. It's really important that the culture should be quantitative culture to point. So we do so in non-metadynamic and socially use conventional cultures where we can establish the antibiogram. And a special chapter for the guidelines for osteomyelitis that was changed some years ago in the two previous editions that we spoke about the recommendation of osteomyelitis the diagnosis based on the proper to bone radiography, and we should check that this is lobster sedimentation as a first step. And with this two tests, is when we can establish an osteomyelitis diagnosis. The advantage of that is that it can be done in everywhere in the podiatric consultation. We can do a diagnosis of all this kind of features with the patient because it is very easy. We just need to put a device there in the through the user, and then you can do the radiography. The normal radiography is something but you can do in your consultation. And with on the test that you can use, and you have that was some image test, like for instance the charcoal food, or when the patient they got severe infections that that are threatening the limb. In these cases, radiography does not give us a lot of information. In this case, for instance, we have this patient with an infection. In a lateral X-ray, we cannot see the change in the calcaneus, but you can see as in the MRI, it is easy to see that we can see that these changes. About the culture of the infections, the bones infections, we need to culture bone. Guidelines are quite conservative here, and they recommend to use the patient in an empirical way, and we just take cultures if the patient does not have a kidney evolution. So the culture recommendations are percutaneous or into surgery because normally percutaneous is quite difficult and, and maybe we cannot get it infected about it. But they use antibiotics. You know that the diabetic foot is a reservoir of reactions, and sometimes these patients they are exposed to antibiotic pressure, and the recommendation is to have a specific treatment and not to use this kind of patient, not to indicate antibiotics in non-infected users because we know that we have to diagnose that from a clinical point of view. So when we start with antibiotics, it's important just to check the timing. We've got some clients, some patients that may come up with 6 to 8 months of antibiotic therapy, and it's not funded on anything. And the guidelines somebody say that for soft tissues infection, we need to treat them between 1 and 2 weeks, and that we can be even for 3 or 4 weeks if the person improves and needs more antibiotics. And if the infection is not solved, then we need to reassess the patient. And so the maximum will be 1 month for antibiotics for one kind of soft tissues infection. About chemotherapy. It depends on medication. We need to know how to prescribe antibiotics. Antibiotic therapy is something empirical. It will depend on the patient. We need to avoid the patient to go worse. And if the patient go worse with antibiotic therapy, so this patient needs to go to the hospital. And so it is important to start with empiric antibiotic therapy with anaerobic bacteria. And it's not necessary to cover the big negative or anaerobial because it is also a trend that we see in many occasions. So not to use quinolones that are normally they have a resistance. Uh, the guide does not speak about covering sediments, and so they can be isolated, but they're not recommended to be covered because it is German. And so it's not included that maybe it can provoke an infection, and when it is provoked, we have some of them. Do you remember exactly the patient because the ceramon it is a multi-resistant bacteria to a lot of antibiotics families. And about the length or the duration of the therapy, the guides have been changing. They came back to the basic recommendation to treat 6 weeks with antibiotic if there is not an intervention, if there is not a surgery, if we're going to be treated just with antibiotics, and 3 weeks after a surgery. Here you can see the dilemma of uh, bones margins, mainly in the rear foot and the forefoot, and also we should consider the concept of cancer that is not considered maybe um, in the case of these patients. I can understand it in the midfoot, but in a long bone like a metatarsal, for instance, we see a clear difference in the cortical, spongious part. So if the infection is located in the head, which we should do is to remove the whole spongious one, and we don't need to culture uh, bone margins. That's my impression. Another aspect that is included by the guidelines is the monitoring of these patients that we cannot consider they have been healed after 6 months monitoring. So it means that the patient, once the injury has been healed, cannot be considered to be right or good after 6 months. And it is this way because of the high degree of relapse or reinfection of these patients with medical treatment. And about the management of foot attack, diabetic foot attack, is a patient that if they need an emergency diagnosis, and normally they have to go to the emergencies of the hospital. We have been, and all these severe infections need to be treated at emergency in the hospital. In this way, the guidelines will establish that this treatment needs to be done. Intervention needs to be done in the first 24, 48 hours. It's not very important. If there is a peripheral arterial infection, we need the participation of vascular surgery. So there is not, so it is always need to see that. And I brought this video here. These patients need to be treated in um, the emergency room with a deep breathing, and these infections uh, is a threat of life. For current guidelines, something that is interesting for me, osteomyelitis is a surgical disorder, surgical condition. So if we see and the bone infection needs to be operated, it needs surgery. And it has changed. Some 15, 20 years ago, we were debating, but the guidelines say osteomyelitis is a surgical treatment. So if you've got an infection in a bone, you need to remove it, but they give an exclusion for these patients who can be treated just with antibiotics. This is the case of osteomyelitis on the forefoot, and so it is what you cannot see that through the user. So in this case, we can give prescribe antibiotics. And just to finish, the guidelines also recommend us on what not to do. Sometimes things that we see in podiatry that is the polymarketing. It's like I, as I for consultation, and I want a lot of patients. I bring a lot of devices and machines and so on. I can attract more patients. Be careful with that because many of these treatments are not based on evidence, and in the context of an infection, they can provoke that things go worse. So be careful of treating the patient with cell treatments or topic antibiotics. We do not recommend to not to use hyperbaric oxygen therapy because all these treatments don't have evidence enough. And now to finish, before going, here you can see the QR code for the guidelines. Anyway, if you go into the International Working Group of Diabetic Food, you will see that on the Google. You can see that also in Spanish. You can download that and you can check it out in deeper detail just for you to put that in practice in your consultation. So thank you very much for your kind attention. Thanks a lot, Jose Luis. And finally, we give the floor to Dr. Monica Derival Valientes wants to speak about antibiotic and cicatrization. Healing. Thanks a lot.
Well, thank you very much to the scientific committee for inviting me to present here, and thanks to my previous colleagues. And I will be talking about local management of the foot disease, diabetic foot disease, and talk about the healing. As you know, the skin is in constant renovation, is a very important and efficient barrier defending us from the environment. It prevents us from dehydrating. And as you know, if you have a skin injury, our organism launches and initiates a series of complex events to restate that protection too. So as you know, our skin is divided into three: epidermis, dermis, and subcutaneous tissue. The epidermis is the top layer of our skin, and as you can see on the picture, you have five there. We have four layers underneath, and this epidermis uh, has an immune system through the Langerhans cells that are an immune defense. So the dermis is considered to be the deep skin, as we can say. It has a connective tissue with collagen and elastic fibers and sweat glands and sebaceous glands, hair follicles, and it has also very important thing is the fibroblastos, who are responsible for the synthesis and renewing the extracellular matrix. Also, the most internal part of our skin, it's a subcutaneous fat. It has um, connective loose tissue and adipose tissue, and it keeps um, our body warm. So what is a wound? It's just a loss of continuity in our skin, and affects in different ways to tissues and close organs. So what does our body do? It starts and initiates a complex um, answer to this injury, and we do not regenerate, but we do repair through the process of wound healing, aimed at integrating a connecting fiber connecting tissue. There are three different types of healing. The first is when we apply with suture a wound with staples or with silk. We get two skin tissues together. That's the first intention. When that wound is not able to heal just by connecting both parts of the skin, then we have to then apply different method. Then a third intention, when we need to reopen, we need to apply to have surgery again, clean the wound, and then try and make it heal again. So what are the stages of healing? Like there are like 3 to 4 phases depending on the literature and that you check. And it's the hemostasia, or an inflammatory stage or phase, what goes from day 0 to day 5. And this is what we call inflammatory process, which is the most important when it comes to healing. And this is that becomes chronic when we have a problem. And the second phase would be the proliferation stage that goes from day 5 to day 11. And here the cells that are involved are endothelial, epithelial, fibroblasts, and the idea is to establish an extracellular matrix that was damaged and reestablish it after the damage, or revert it to the state prior to the damage. And then the last phase will be as of 11th day and up to a year, where we have this remodulation with the cells taking part will be keratinocytes, microfibroblasts, and endothelial cells. So in the first phase, inflammatory phase, we know that some cells send some signals to tell other cells how they need to behave. And so the neutrophils are the important cells here that generate free radicals to kill bacteria, and they debride the wound with some proteolytical enzymes, and they also actually eat dead bacteria and the remains of the matrix. For me, this is like going to war, and the neutrophils help us. Neutrophils, they help cleaning after the war. And so in the second phase, proliferation phase, it's when we have some growth factors that recede, but they call the endothelial cells and the fibroblasts to come. Now we've cleared the battlefield to start rebuilding again. And looks like, the blastia, it's being formed, swelling. There's less swelling. And in this phase is where they create this granulation tissue. And so now the battlefield is cleared and clean to start building again this matrix, the extracellular matrix. Fibroblasts are critical because they produce collagen, fibronectin, glycosaminoglycans, and other substances that help building up the matrix again. And they reproduce the natural. We can do this in the laboratory. We can use these cells to reproduce the natural healing process. Then the last phase is the remodulation, is the last phase of the healing. And the scar, it starts contracting. The type 3 collagen is destroyed, and depending on how much collagen, we can see a normal scar depending. And the idea is that after this remodulation phase, we consider the healing process to be finished. But after 6 weeks of a proper treatment of the wound, if it still prevails, we're talking about a chronic disease. Um, so why are they chronic? There are myriads of symptoms delaying healing. Patients with chronic diseases, diabetes, malnutrition, aging, drug abuse, and many different factors when it comes to at a molecule level. We have two theories saying that the inflammatory phase can become chronic because there are too many neutrophils, and this will end up in an excessive oxygen production, which will damage directly the extracellular matrix. Or there are too many the macrophages are not they have no time to do their job and properly um, clean the area. So this is when the inflammatory process continues, and it's the idea is that we need to clean and humid healing of the wound to reduce the bacterial load. And the idea is to reduce free radicals and stimulate healing, wound healing. How do we do in order to break this cycle? We just need to clean the wound and debridement, and at a general level, when the wound is okay, that we can act at a local level with the apposits and different ways that I'll show you. So the diabetic foot has been mentioned, and it has been mentioned the different factors present in these patients, and we expect to find mainly an ischemic patient, ischemic foot, and also we find neuroischemic wounds that need good metabolic control, and it's also very important to control the pressure in the neuropathic patients. A diabetic patient, when it comes to a holistic approach, need every case is different, of course, but we need to take into account this acronym DOMINATE, which is debridement, offloading, moisture, infection. The moisture needs to be kept under control. We don't want excessive moisture and lack of moisture, but also inflammation and infection, nutrition. Also, we need to keep track of the proper diet and make sure the patient has a proper diet, and arterial insufficiency, and also needs to be taken into account. And also, if the hospital has technical advance, we can revert to them. When it comes to the local approach of the wound itself, we need to follow the TIME acronym, which is a practical guide and dynamic to optimize the wound bed, and it's based on moisture healing. And the idea is to prevent from any, the T is control of the non-viable tissue. I, it's control of inflammation and infection. M is control of the moisture factor that takes place with these patients, and the stimulation of epithelial And so our goal with the T, with the non-viable tissue control, we need to eliminate the tissue as not vital tissue. So the and so it's important to have a proper offloading. The wound needs to be clean as much as we can with physiological serum and antiseptics. And debridement, we need to take into account the general state of the patient, the anatomical area where we need to debride, and we need to see vascularization, if it's possible or not, and control of the pain. Some patients needs to be taken into account. The methods of debridement, we have the surgical, we have the partial or total, autolytical, enzymatic, osmotic, um, larval and mechanical. We need to distinguish and make a difference between neuropathic and circulation, and in neuroischemic can be less or more aggressive. The idea is not to damage the viable tissue, and if it's ischemic, it depends if whether it's revascularized, if we're able to revascularize it or not revascularize it to avoid gangrene. um, and this has been mentioned by Dr. Lazaro. We try to keep control of the bacterial load. And the M is try and control moisture and make sure it's not too moisturized, not enough moisturized. And for this, we can see if the wound keeps exudating or kind of sweating. We have, if it's very little moisture, we need to apply hydrogel, hydrocolloid, and transparent film of polyurethane. And if it's mildly moisture, hydrofiber of hydrocolloid. And if it's too excess of moisture, we need to use polyurethane foam. And so, well, it's important these exudate needs to be managed with also different barrier films that we can use. Could be used in spray or in cream, polyacrylate, to help protect the skin surrounding the wound. And the last phase, the fourth phase of this TIME acronym, will be to reestablish the epithelium and the function of the skin. And in complex wounds, as is the case of diabetic foot, we need advanced therapies, like collagen apposits, cellular therapy. It's also recommended for wounds without infection. Also, surgical repairing, topical therapy with oxygen, and apposite impregnated with octasulfate of saccharose. This is for neuroischemic ulcerations. And we have been working extensively with amniotic membrane cellular therapy, and for the good proper epithelialization of chronic wounds. So you can visit our website and read our research and our published papers. Thank you very much.
So that is my opinion. To add anything else? So depression, it is something that is also considered, as Juan Pedro also mentioned, these comorbidities that we can see. It is also very frequent, and so we see the results of the patients, and there are more amputations, and also we see the cognitive deterioration due to neuropathy because it doesn't affect just the food but also all this system and so there are patients that you follow a lot and you see how they lose the cognitive capacities and it affects the therapy so these patients sometimes they not follow the instructions because they do not understand because sometimes that is why they die. So it has it plays an important role. So first of all, I wanted to congratulate the whole round table and the moderator for creating this panel. But I would like to ask you a couple of questions, and then I give you the floor. And the first question can be for Gabriel or for others. So you spoke about metabolic control. You said it will be seventh, correct? But I want to know what is the feedback when you ask for the seven for the internal doctors in another atmospheres. So, because of these patients that they are in a risk of diabetic food, then with comorbidities, and normally we don't give them a seven as a sign. So I don't know if you have a feedback at this regard. So it will be one of the questions. And did the one read about the dominant charisma? I don't know if it was Monica. You said that you were waiting, you maybe you expected in this mechanism to have this in this comprehensive approach of the people, the patient. Thanks a lot for the question. Yes, you commented the guidelines. They normally mark this higher line of a 7.5, 8, or 8.5 for this kind of patient. When I told you this 7%, it is about the predictor that is linked to male, to MALE, with this severe effect. So you see diabetic foot, but not just this, people without diabetes, but with high hemoglobin, and you need to treat this kind of patient this way. But effectively, when you see the guidelines, the other value is the other one that is recommended. Obviously, they are quite old patients with a lot of morbidity, lot of treatments, and sometimes you want the seven is too much. It's like high, you better take that. I also wanted to comment that effectively there are a lot of comorbidities in a patient with diabetes. That is difficult to establish a dominator. But they wanted to express a want, but there are that big amount of things that we can find there that will be impossible to just to bring it to a presentation. But yes, not just we should just not to measure only this, but many other things because every patient obviously has a lot of comorbidities. If you allow me to add something, the main problem is that the context of diabetic food is the sometimes we focus on the ulceration, and most of the algorithm that we use in the injuries management is that we send that to diabetic food, and sometimes the timers that dominate moist. I think that is important to remember that the standard in the diabetic food treatment is mainly revascularization, discharge, and local management based on evidence to reduce variability. Otherwise, we will do what we want, and the results will be different. if we take care of these five main pillars, I think it's going to be the most important thing. Our charisma, I think, is a macro on this picture. What you have to do with this or with the other, but I think it is important to remember the standard and the reason why diabetic food. I think that's important thing. When you've got an ulcerated patient, you need to control ischemia and to do a good discharge. And if these points are clear, patients will go okay, and if not, it will be really uh, not very frequent. Any other question in the room? But so as we want to be in time, and we are now 1:30, we are going to put an end to this panel. Thank you very much for being with us. So, good afternoon. Now we're going to start with the last panel for this conference, and we are going to talk about the clinical approach, and we're going to speak about the plantar fascial. Sometimes we say that is the most horrible pathology I can find. The patients consider will never improve, and so we consider it would be good to give a different point of view, maybe to have a look at what we are doing on this pathology. So now we're going to speak with all the speakers, and because as we know, it is a big incident and we've got four big specialists from podology, from podiatry, and for sure you would recognize them. And so in this we just prepare this panel from the less invasive to the more invasive strategy. And so I hope you enjoy that, and that so we want that to be a golden closing, golden end. So we're going to start with Dr. Miguel Blanco Traba with a presentation called Factors Influencing Recovery from Plantar Fasciopathy Treatment Proposal. Thanks a lot. So good afternoon, everybody. We're going to continue with the same line to which we did this morning, and we're going to speak about content that I really like. When they wanted me to do this presentation, asking me what can I help can I give to my colleagues? So, first of all, I have to say the first question: Are all fasciopathies the same? Should all these are all fasciopathies treated the same? Because that question comes because speaking to other colleagues, they say that the fascia is the whole plant of the foot. Or for me, fascia is when we have a pain just one point in one point or the other. But within fasciitis, there are like all those things. So we all have seen this. Why do some have a better or worse prognosis, or respond better or worse to certain treatments? And that is what we're going to try to explain now. We're going to try to make a classification that's never easy, but in my experience, it's not that bad anyway. So the um, about this incidence peak that we can find. Normally, it's between 45 and 64 years old, more commonly in women. 10% of the people will suffer this pathology along their life. And the main problem here is to be a lot of time standing on the time and also a bad selection of the footwear. Okay, mainly during sport, and dorsal flexion on so limited ankle dorsal flexion is also some of the limitations. And in the sports people, we should highlight that doesn't matter what is the intensity, if it is a professional or amateur or a beginner, there's no relationship with this. So, what are the risk factors? So, so we uh, we find some relationship on others, but not in the sportsmen. And also there are cases where some patients normally they give up smoking, and so they get some put on weight, and this can affect. And the study also comments that the muscles around the ankle normally are weaker when there is a plantar fascial, and also there are some rheumatic um, conditions that affect this. About the professional footwear, there is not big information about that. It appears to be designed primarily for occupational safety purposes rather than functionality or comfort, and this is a risk factor for plantar fasciopathy. And also, a case control study found that obesity and weight bearing at work were risk factors, although decreased ankle dorsiflexion range appeared to be the most important. And also, about 82.2% of the patients with plantar fasciitis reported wearing very flat shoes, and 55.5% wear shoes with hard, non-cushioned insoles with no bedding arc support. And in another study, participants who wore inappropriate shoes experienced more severe pain than those who did not. And when we speak about that, we also need to carry out a good anamnesis as we did this morning. And we also have to assess if there are more pathologies. For instance, we can have a traumatic or mechanical cases. For instance, we can have a calcaneal spur with a fracture, bone edema, or a nerve compression, and it can be a cause of pain. And also the atrophy or damage of the plantar head pad. Also, we can identify the bone edema or osteolysis in the medial calcaneum tumor, or we can find also neurological conditions like a proximal and distal baxillary nerve compressions, dorsal tunnel, radiculopathies, lumbosacral neuropathy, diabetic, also rheumatic, and muscle. And sometimes there are some diagnosis that says, I made a good improvement after 2 weeks exercises. Sometimes it says overload or trigger points, or it's tumor. Sometimes there are cysts and vascular arterial of Venus. So let's have a look to the first year. What can we see from the evidence? So so we can see that the study at a normal an average speed of 4.2 and 6.67 millimeters, and it will be also a difference according to severity, and also there can be differences. So we can have we can go all in the same line, and this study is quite important. And Franco mentioned that this morning, they compared two groups, one with the condition, and another one that's asymptomatic. They compared that asymptomatic plantar fascia with a contralateral asymptomatic plantar fascia, and they found a thickness of on the fascia due to the weight transfer. And but in the control group, the fascia of both feet were less thick. And also we seen that it depends a lot on the age and the body mass index, and also the time. It is going to affect everything, the pain, diagnosis, and treatment. And 93% of this, in these cases, we will find that. That's also important. One study revealed that the vascularization of the fascia was associated with pain. Both the vascularization as well as fascial thickness are associated with foot dysfunction and plantar fascia. In another study, contrast enhanced ultrasound, they found that uh, that 83.3% of the patients with this condition showed visible hyperfusion. How can we know if we are improving? First of all, there is a reduction in the pain, but how can we check that from an objective point of view? Mark Howard saw that the reduction in fast thickness on the, 1 centimeter, 1 millimeter was correlated with an improvement of pain. And now, analyzing the fascia, look at this. In the fascia, we've got intersectional, 66% of the cases, non-intersectional, 34% of the cases, and mixed, 22% of the cases. And there is another kind that we will see later. Here, we can see a normal fascia. We see that it is about 2.9 millimeters, and we see here fasciopathy, and it is a little bit borderline. This is 6.6, a little bit thicker, and this is a little bit more severe, 7.5, where we can see the collagen structure. Let's have a look to each of them and see the prognosis. In the interstitial that are mild, they normally have a thickness between 4 and 5.5 millimeters, very relative to weight, height, and previous damage, compared to with a contralateral with 2 millimeters more. Normally, it comes with mild functional disability, discomfort with getting up in the morning, improvement along the day, and even disappearance of the pain throughout the day. In the ultrasound, we can see the preservation of anatomical structure and some chronic areas with a good prognosis of between 3 and 9 months of from treatment. And just with our orthotics and footwear, that's enough. We can help with shock waves or laser or other things. And about stretching and massage exercises is also good. So, and then we've got insertion and moderate. Here we have thickness in between 6 millimeters, and in this case, we see how the pain can even be worse along the day. It's a preservation of the anatomical structure we can see in the ultrasound, and although diffuse in some points, such as the anterior area of the calcaneus, and we can find a gap. A gap is like a hole, it's a small break that we see in the transversal area. The prognosis is low but continuous. It means that the patient will improve by little by little. So when a patient has a fracture, that needs to be a plaster and wait for 1 month. But it's more than 1 month. That's going to be very slow, between 6 and 12 months, even more than 1 year. We can make a treatment, so try to accelerate it later, but normally between half a year and 1 year. In this case, I used to use normally shock wave and electrolysis and plantar orthesis and footwear. If it is for more than 6 months and we see that is very small, so maybe we can change it. And if we see in the case of intersectional severe, where there's a breakage, so we can see that maybe it has some amounts of evolution. There is a re uh, rupture or re fracture, and after maybe sometimes for example, have a case that had a re fracture after the 8th month, and so it needs to be understood as a severe case. And here the thickness is between 7 and 10 millimeters. In my case, the biggest one that I found was just 11 millimeters. It normally provokes a functional failure that is going to condition, is going to affect the support and the daily life. And it is like a patient that comes and you can see a pain in the face, and this person cannot even stand up. Could have also angiogenesis. And we see also a loss of the limits of the anatomical structures, even intersubstances. We can see also big hypoechoic areas, and we can see big gaps. The prognosis is very slow, normally even more than 1 year. About the treatment, we've got um, orthosis and footwear, but if it is compressing the fascia, we need to reduce the pain. And here we can use laser during the 12, 14 sessions in acute cases with severe pain, serial tape off, but for offloading bandages. Sometimes we can use an discharge boot, so we can use other treatments such as electrolysis, hyaluronic acid, or corticosteroids. If the fascia is fibrous with our recent tears, we can use PRP. That would be ideal, or surgery that my colleagues will comment later. Look at this case here. In this case, it's the 1st of October for previous Tuesday. This girl has vascularization in fascia, and as you can see, the caps intersubstance and perifascial oedema. You know for how long she's like this? 10 months. And this injury is like 1 month ago because there are constant rebreaking because she has overweight and she spent most of the time standing up. And um, and this person needs a discharge. Stop. And stop. To speak to the doctor, we need just a sick leave and stop. Otherwise, nothing is going to improve. And also, now we have another this non-intersectional middle third that are made, and here the footwear is going to affect a lot. So it normally improves with semi-rigid soled sport shoes. And there's a good preservation of the limits of anatomical structure in the ultrasound with good prognosis between 3 and 6 months after treatment. A conservative treatment is usually is enough, and orthesis and sport shoes. And then we also have a possibility that is non-sessional, middle third, moderate. Now we are talking about a thickness between 4 and 5 millimeters with a more functional disability with irritation. And this orthosis can be uncomfortable without a very corrected end. We see a lot hypoechogenic zone, no angiogenesis, preservation of anatomical structure in ultrasound, and sometimes we fibroma. In this case, if it is chronic, we can use a much more aggressive treatment with PRP, multipuncture, and so on. And if we have a more severe or ruptures, it is very, 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 very slowly treated. Normally, it have a thickness of over 5.5 millimeters, and we see that the pattern. The body pattern is low, so we normally see some breakages and or ruptures and gaps. There is angiogenesis, and it is like a double cure aspect. It is the fibroma, um, and it's quite slow, more than 10 months. About the conservative treatment, if this organ cannot be used, so first of all we need to reduce the pain with the serial tips, electrolysis, PRP with the discharge boot. We need to reduce the pain, so to start with the treatment. And if it is a very acute case, we can discharge. Or if it's a better, if it is more severe, we have to break that without mercy. In this case, for instance, it was for some 6 months. In the same case, 6 months, 8 months with this injury, with he was infiltrated with corticosteroids twice, and the re-breakage, re-ruptures. You can see the gaps here, the gaps within the fascia. We need to give it time. And sometimes extrinsic factors such as work, weight loading, the footwear do not help. And look at this case where we do not see the substance. It was a major rupture. And there is a kind of ascites that we were commented with Paula the other day. Says, okay, for me, the most difficult ones are the posterior because there is a compound of traction. Yes, for me, I just saw a couple of them in my life, and normally it's quite difficult, and sometimes we can see gap, a small rupture, but should be quite uh, vascularized, and it normally is a poor prognosis, and we need to introduce cushioning on the heel. And in this case, patients, a lot of and if we use an intervention treatment, so we need just PRP, electrolysis, multipuncture, or corticosteroids. And according to the treatment for the pain and functional disability, if we have a low medium pain, so orthosis and footwear for 6 months, this should be inappropriate, maybe. If not, we can help with physiotherapy, stretching, laser force, shockwave, dry puncture, electrolysis. So many of my patients can say, okay, I got, yeah, if you want to accelerate that, we can do the treatment. Say, no, 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 it's fine. I go improve. And in 1 year is good. And most of them, they heal. And then we have the median pain, median high pain. But if we don't have caps or ruptures, normally there is a good evolution in 5 6 months. If not, what have is shock waves and so on. Or if not, the more aggressive ones, we need to use PRP, hydrolysis, and hyaluronic acid, and so on. And about the footwear is to be a good one. So normally, and then comes at home and take the slippers for 1 hour. It's always losing the time. And when they tell them, please, okay, don't do it. They said, okay, what is the problem if I use slips at home? And since they do that, they improve much more better. And so, and when we have a severe acute pain and great disability, if there are big ruptures, we need to take care of the foot. We need to install bandages, analgesics, and chemotherapy, unloading boot, sports footwear, and also should evaluate interventionism if there are ruptures. If there aren't, so no mercy, we need to break. Shock waves, corticosteroids, or even what we do is an electrolysis with a thick needle, 27G or 20G, with a puncture and with electrolysis, such as the double PRP or the B or bivalent needle surgery for vasectomy that we can do ultrasound guided. We can break less fibers so to be less aggressive and to discharge and then miss open and so on. And even in order to finish, let me tell you, there's something quite curious that in some cases, we saw that ultrasound multi-culture shows a superior result to corticosteroids in pain at 120 days. The corticosteroids were quite good at the first month. And multi-puncture have shows better results because it's breaking this fibrosis, these fibromas, and the collagen. And so what we do there is a hematoma that is helping the healing. And it's because you accelerate the healing, you stimulate a healing response. And as a result, in osteopathies with the long evolution, with our recent re-ruptures, we must break up tissues. In recent or chronic fasciopathies with acute or the re-rupture phases, it is usually more conservative. And you can use this QR to download this presentation, and you've got more pictures of what they have been doing, and also some samples of good important things, good information for you. Thank you very much for that. Thanks a lot, Miguel. Okay, let's continue now in the table with Dr. Javier Alfaro Santa Fe, who is going to speak about the efficiency of conservative treatment in plantar fasciopathy. You've got the floor.
Hello, good afternoon, everybody. First of all, thanks to the scientific committee, the council, and thank you very much for organizing it. Congratulations. You made us, lots of people travel to Cartagena. You put it on the map. So now it's my turn to talk about the efficiency of the conservative treatment in plantar fasciopathy. And I'll ask, if you ask yourselves these couple of questions, and if the answer is yes, then it's conservative treatment. So first, is there a fasciopathy? If the diagnosis is not correct, then conservative treatment will not work because the insole. So we need to have to study the case, and then we'll, depending on what we see, then we will find a treatment. If there's neurotic pathology in this area, and so depending on the situation, we have to ask ourselves, is there a fasciopathy? And then secondly, why did this injury happen? If we find the reason why it happened, then we'll be able to find a solution, and we'll be able to aim at the best solution. If it's a neurotic pathology, the Achilles, the calcaneus, um, plantar fat. Okay, this will help us. There is a high prevalence in society. We see it's higher amongst sports people. It's a higher rate with obesity among obesity patients, and it also increases with age because the fibers are less and less elastic. There's more strain, and it could be one of the cases why there is a higher prevalence after 45 years old. As you know, fascia is a connective tissue which is quite dense, composed of collagen. And if we see in the microscope, the parallel fibers of collagen are mixed with elastin proteins, and which changes the whole behavior of the fascia because the protein can elongate 150% of its length. So that's why the collagen does not break. If there was no elastin, the fascia would break more easily. Now, there's some forces generating this injury, and collagen is very strong and resistant to axial forces, but there are some tangent forces and then compression forces in the heel. And it's something we don't find so much often in the literature, and it's torsion forces. We've seen when there's a pronating foot, the fascia insertion is quite distorted. So this insertional fasciitis, we need to understand that torsion mechanism and understand how to prevent it from being so distorted. It's not always like in it's like when we can see in this video now. This can be measured, and we starting a research with Antonio in a gyroscope to try and measure the exclusion from pronation to supination. So when it's over 25 degrees, that's when we start considering if maybe it's that in fascia insertion contributing to the distortion. So, and you have this article from 1953. That is the first article or a scientific paper that spoke about the Achilles tendon is connected to the fascia, and for mechanics it was pretty clear that there was a connection, but for the anatomists it wasn't all that clear. We've seen some articles, papers from Javier Pascual where they explain this mechanical connection, but not from anatomy point of view. This is a paper from the Dr. De Checo, and where she talks about the plantar fascia anatomy and its relationship with the Achilles tendon. And this video is just for you to enjoy it. It has music. We can't hear the music. This is for you to see the energy, the amount of energy that the system can get. It's incredible. The elastic energy of the whole system needs not to be blocked, so that we have an insole that helps the system rather than not helping. It looks better with some music. Dr. Kirby listed 10 functions of the fascia. It keeps the A alive, and we need to do how to preserve it. The will-less mechanism described by Higgs, and last but not least, it captures energy and then releases energy when gaffed. And so I can share my presentation with you, no problem whatsoever, so you can be able to see. So why do we have an injury in the fascia? There might be some stress due to impact. There are some risk factor that are intrinsic and extrinsic. Extrinsic. There is an, a tissue injury, acute tissue injury after this mechanical stress, and then there's an inflammatory process, which is a fasciitis, but then the tissue is regenerated, and then if we don't um, spot the harming agent, then this fasciitis will not heal. It will, so to speak, reinfect. So it will have a fasciosis and fasciitis together at the same time. Risk factor, excessive pronation. The first MTP joint is critical, so we need to study it well. Limit the ankle FD, also the dynamic simultaneity surface, which is very interesting. We'll see it later, and also extrinsic factors, how long we are standing for, and the type of shoes we're wearing, and the exercises we do. There are loads of papers saying that the insoles improve the pain and the function of the plantar fasciopathy, and also admit in long term. And there are other papers saying that at a short, mid-term, insoles have the same efficiency as the corticoid injections and infiltrations. I am not in favor of corticoid infiltrations. It depends on the circumstances of the patient, unless the patient is really in a rush. Then of course, I infiltrate the patient, but I think there are with corticoids, but I think there are other treatments better than corticoids injections. Here in I use ultrasound, even if I don't have ultrasound guided need to have this ultrasound guided exploration, and we see different degrees here to the Barrett plantar fasciopathy grading system, and it's the thickness is not really relevant, because you can see if the fasciitis has improved, the patient feels good, and still the fascia is quite thick. So thickness can be quantified, can be measured, but it's a more important the aspect, how the tissue is, rather than the thickness of the fascia. Now, when it comes to biomechanics and the insole, I use 3 different pictures of the Dr. Kirby, and then this is all these 3 main concepts I use, and they're important for fasciitis. Dannever, sagittal plane, and the first MTP joint, Dr. Kirby, medial axis will generate more tension in fascia, but also posterior tibial will be more saturated. So if the axis is medial, the fascia doesn't have to elongate. So, but this won't. This will end up in failure. So. Anyway, all these 3 theories, sagittal plane biomechanics and the evaluation and management of foot and ankle disorders, and rotational equilibrium across subtalar joint axis, these 3 papers are critical for me. So many times when we see the patient has already is already injured, and probably by the time they come to see us, they've gone to the physiotherapist, the GP doctor, and they've had the problem for a while now. So, in subtalar joint axis location of Kirby's, basically Kirby's theory, I have this picture here for you to see that torsion of the fascia insertion in the calcaneus. The treatment of choice here would be medial heel sky. Problem is that if the fasciitis is too inserted, I am increasing the compressive forces, and if it won't be tolerated by the patient. But if it's not so inserted, what I do is I change the uh, the rules of the game, and the arch needs to be very tight and fit, and we need to do a deep research, take the measurements of the foot, and I need a full holistic study. If we get this image from the ultrasound, I cannot use medial heel sky. So what will we do? I still remember, maybe it was over 20 year, and they were asking for senestration. They were suggesting senestration, and so and if you fill it in, the fasciitis improves. For me, that was a turning point, really, and we need to mold to helps not so that the intrinsic bone structure doesn't feel really too compressed, and that the fasciitis will improve then. If we see that, we need to be very careful with the insole and has an intrinsical medial, and we don't want this shearing. This insole has a medial, but we don't see compression in the uh, fat of the heel. If we see that the medial has collapsed, we need to keep geometry. It's important that the arch doesn't have to be round. That's not the natural arch, and we need to have an arch respecting the natural geometry. If this insole will help the intrinsic muscle, which in turn will help fasciitis. So let's now move on to Dannenberg's theory. For me, the treatment of choice in forefoot, initially, at least, is an epic. We need to have the first MTP to go up and the windlass mechanism to work better. The fascia won't have to work as hard. Maria has described in Higgs described it already in 1954. So kinetic for me, it's really important. So when you do the mold, you need to take into account that it's going to have a kinetic, and you need to take this into account because if I know that the head is going to go down, if I open the door for you to leave, if you don't want to leave, I open the door for nothing. So I will probably the temperature in the room will get colder. So if when we do the molds, we need to make sure that a kineptip is going to be inserted, it's going to be used. This always in an insole, put it in under a foot with a positive jack. If kinetics of that insole is proper, it's well done, we're going to have this. Uh, if the insole does not play negative, then it's not a good insole. And here, this is a jack. and it actually moves a lot, but fascia is not moving. So this patient has a tendonitis of the flexor. So what I did is an elongated Morton elongator, which is applying tension in the fascia. So I want to generate tension in the fascia to help the tensor. So I include this Morton um, enlarger. This article from Erdemir, we can see with fiber optics the tension of a fascia is communicating with the Achilles tendon, and so according to him, if the Achilles tendon force is too tension, this is a predictor of plantar fascial tension. This is also part of the doctoral thesis of Jose Victor Alfaro, and taking into account this dynamic simultaneity surface. Um, so it considers the surface when the heel and the MTB joint are touching the ground. And so this uses a very complicated algorithm that tells us how likely that patient is to develop fasciitis, plantar fasciitis. If you see the patient here, um, her her ischion is shorted, and the cufflinks not so much. And so we can measure this with inertial systems to see the dorsal flexion when she is running, which is her usual sports movement. And the third theory, we had pronation, sagittal pronation blockage, and then this last one, this deformation and the stress of the tissues. This is something that the insole needs to take into account. If it doesn't happen, it's going to be impossible for fasciitis to heal. We see the top image. This is the movement of the insole. This is calculated with finite elements, and we'll see how much flexion or how much this insole can bend. As it's not about a soft or a hard insole, it's how much it can bend. And we can see in a flat foot, we need to block the arch, but there's no absorber, shock absorber, and the other one, it's a cavus foot. Anyways, and that can be calculated. And so the insole needs to allow the fascia to move. If it doesn't, from the mechanical point of view, we have understood how it works, but we didn't relieve the stress of the structure to relieve the area. And if it's accumulating strain, it will end up developing an injury again. When we have a pathology associated, you see my hand here with fat, very soft fat in the ankle. There's no fat syndrome or syndrome in the plate as such, or fat in the plate as such, but in these cases there is still a lot of fat there. In these cases we need to absorb to cushion and to absorb the shock, and then we also need an entrapment degree. We can see that the nervous branch has been trapped. So if that insole does not respect the geometry of the abductor, because we've made a round arch, then we're going to increase the compression of the abductor. The entrapment will get worse, and the clinical situation will not improve. So it is paramount to maintain this geometry. When you see a foot like this, if it's compressed with the insole, this patient is not going to improve. Just to summarize, we've seen thousands of patients, and when they come to see me with fasciitis, I like it, and I tell my patients there are very few patients that I can assure them you're going to get better and recover 100%. But with fascia and fasciitis, it is the case. You are going to recover 100%. How long it's going to take? I don't know. We'll see. But with the algorithms of the treatments we've had in our research center in Huesca, if it's a cavus foot, there's a lot of tension, and there will be what we need to do is to do this heel wedge, 4 millimeters, not too hard, and there's some tensile component. We need a wedge and control pronation and regulate elasticity. I always want a mold to contain pronation but not compressing. Can use a heel sky if it's pronation, and fenestration if the opposite, and 4 millimeters if the face is acute as a wedge. Heel 2, 3, it depends on the case. But different pathologies can be associated, or we can work around different pathologies, and we need to be able to offset and from one place, well, study every case and adjust a little bit. This is my team. We have an IT engineer, an artificial intelligence engineer. Antonio, you know him very well. She's a biotechnologist, and Jose Luis is a doctor in sports sciences. So it's great. We have a wonderful team because now we can do things that were beyond um, are out of the scope, and so this we can see here. I had the chance of helping sportsmen, uh, and I wanted to share it with you. Thank you very much, Javier. Um, we now will continue with the round table with Javier Alcalá Sanz, who's going to talk about the decision-making criteria in ultrasound guided. And thank you.
For your kind invitation and the patience that you've got in this time. So thank you very much. At the end, we're here. That's fine. And when Jose wanted me to prepare this round table, he wanted me to speak about ultrasound guided treatment. So he said he wanted to do what to do with the fascia when there's not good answer with the preservative, the conservative answer. So when you read this title, it's like you want the magical formula. But unfortunately, they do not exist, and you will disagree with me. And we've got a big deal of treatments at our disposal, more conservative, less conservative, and others that are more surgical, maybe. And I always consider the same. When in pathology, we've got this big amount of treatments because none of them work in all of the cases. And as we have a lot, and every year we've got more, so maybe we cannot just have one way to treat it to everybody. So I could explain to you what I do in three slides. That will be my last three slides. But I spoke to Jose with about the possibility to explain the reasons why we do all this, and also to share some reflections or things that I consider for a chronic fasciopathy. So, what do we consider by that? What do we mean by chronic fasciopathy? So, big deal of them that will who could have a good answer to conservative treatment. So all the possible treatments, conservative treatments that we know, and most of the cases, when studies say that yes, that they will have a good response. But we still have some 10% that then we will not respond. And so we need to go a step forward and do another treatment. If we have a look to Barrett guidelines, Barrett was trying to simplify this and to make an algorithm, and it gives us information. It says that more time of evolution, we need to be more aggressive. But I don't understand it is the law. If you have a look at this table, it depends on the thickness and the time of evolution and opportunity. And then is it the same for all the cases we see in the consultation? Okay, I don't know. So let's have a look at one case I had this week. 74 years old man coming in here at the beginning of the summer. And these pictures are quite recent, but the fascia was exactly the same. If we see here that both fascia, the healthy one, there's a 0.74 is the limit of pathological, but if you see 0.74 is pathological fascia hyposinity, and then the fascia normally gives some discontinuous symptoms, and then the symptoms are stayed forever. And in this guide, we use a fasciotomy because with this thickness and so on. But the time of evolution says something different to me. It will depend if it has been treated or not. If there were no treatment, it's not a year of evolution. And I have to bear that in mind. This picture is quite recent, and so it's last week. This patient has not have symptoms with this fascia, and I only gave an insole and education about the footwear. I do agree with what Miguel said. So you should use the same um, footwear at home, and because there are many patients that didn't get footwear at home. And so it's first as like this that things we have to do, but we need to listen to the patient. And so from this very moment, we decide what to do. So this part is also considered in these studies. And what they considered was doing an MRI in patients with clinical osteopathy before doing the shock waves and then in monitoring for 6 months. And what they saw is that it was a good response, but no significant difference in facial thickness. Sometimes when the symptoms disappear, the thickness is the same. There's not an improvement. Maybe because it's not just a matter of quantity, but quality of the tissues. And so, but you can see here, 80% of the patient improved. So where did we see some improvements in the periphacial or edema reduction? But the fascia, more or less, from the MRI point of view, was almost the same. There's something similar was what we found in Barcelona, where the pain does not correlate with the thickness of the fascia. So it's not a variable, what serious one, when we want to establish the seriousness of every patient. And so we can think why do some fasciopathies give you chronicity? Here in the table, we spoke about risk factors. The, the obesity is one of them. Everything related to calcaneus and plantar system, muscles, and so on. And I always miss in these studies a couple of things that we normally do not mention because we don't know how to measure or because it is difficult to measure. And one of them is the quality of the fat pad. Sometimes our patients are 50, so 60, 45, and except the sportsmen. And so the fat is going to protect you up to a point, but then the function is not going to be good. But then it does not do this. It's a work, and so it's going to compress the insertion. But not just in the insertion of the fascia, but also more things we got there. So fat is difficult to measure. We can measure compressivity, but it's difficult to work on this. But I think that the a good point would be the loss of quality in this fat pad, and not the morphology of the medial process of the calcaneus. In this case, it is a patient, one of our patients. She's quite old with a very severe atrophy. You see the hyperkeratosis from pressure. And pressure is very, very, very concentrated at this point. It is the fascia insertion. And as in other pathologies, we understand that anatomical factor purely anatomical is related to pathology. So when we see we see that is because normally there is a second long radius, or we see the convexus, so it would be so we normally when we see something we know what may happen, and we know all these anatomical factors, but we never know we speak about that in the case of fascia. We speak about mechanical aspects maybe, and many patients do not improve because they've got a process that is quite big, like the one here with a fat part that is not very efficient, and it takes us to the need in this case of patients. d- we should try to encapsulate this heel and see if we can do replicate the job done by the uh, pad. About the pathophysiology, for some time, and this paper was published in 2003, and it changed the idea of fasciitis, fasciitis, fasciosis, this thing that happened in the tendinopathy, and in this case of lemma, in the histological case, we spoke about there was not a swollen condition in the spore. And so from this very moment, we wanted to question just the use of corticosteroids because so the case was way to use anti-inflammatory in this case, and they introduced this concept of fasciosis that is now a fasciopathy, a degeneration of fascia. But I can consider now something that was commented that sometimes itis and oocysts go together because it is fasciitis is not going to be an irritation of the fascia. And that is why this patient feels that pain. Or as Miguel said before, this process comes from fasciosis and becomes a fasciitis because there are re-ruptures. And so maybe the problem or the bias that we have after many ultrasounds is that we focus on the fascia. So we only check the fascia, we see the thickness, the characteristics, and so on, the breakage, and these gaps that we can see. But it is true that through the ultrasound, we see good things like alteration of the fibril pattern, or maybe some focal breaks, or delimitations with a lack of collagen, and we see interfascial calcification, calcaneal spore. But in ultrasounds, we do not see bone lesions. We don't see these edemas, and the peripheral edema at a certain point. But also we can lose some vessels, and so it's difficult to see that completely. So we are losing this part, a part of this edema, because we don't have this sensitivity. And then we should consider if it is just the fascia, because as we commented yesterday in tendinopathies, in this place we also have all the tendons, and there are intrinsic muscles with an anatomical and clinical entity. And in this paper by Christian in 2019, they spoke about that. Sometimes we speak about fascia, but it is a tendinopathy. The intrinsic muscles can be also covered, affected. And it's more or less the same that was expressed by Grady in 2023. We spoke about Panther cities or digital brevis myositis. And so it was just a biopsy of 5 cases of these 5 recalcitrant cases. And in all the cases, they presented inflammation, degeneration, and atrophy of the short stalk, what we call a meiosis. And so maybe sometimes that's the reason why that's not healing. And out of 2 of the cases, they saw inflammation swelling inside the fat with the lymphocyte macrophages and so we see here fasciosis with peripheral inflammation and so on. I'm not going to take long here because Miguel spoke about all these differential diagnoses that we can have. Sometimes it is not just diagnosis, but many things like fat and so on. And but I want to highlight the bone oedema because what we see in the ultrasound is limited to fascia, but these bones and peripheral tissues is something we cannot see that good. But when we see the MRI, we can take it out and we can see the inflammatory process around. And something we can also see in these control cases, in this here they speak about the need to establish new phenotypes because there are fascias that they have more bone damage or stress or muscle damage, and so we can have different fasciopathies. And they thought about the need to establish biomarkers, so things that tells you in the MRIs and prognosis. And they saw an association of the cases with a better, worse evolution with calcareous edema. And also, apart putting that aside, if we speak about the treatment uh, and monitoring guides, we see that we have had a multitude of studies, obviously, and we see that there is an overall poor quality. And why? Not because the studies are bad, but there are just a few prospective randomized studies, and there is a lack of homogeneity in the protocols. And in one place you do one thing, and in others the other things, and so on and so on. Just give time, plus anesthesia and whatsoever. So it is difficult to do something homogeneous. If you speak about PRP, there are some people they put three as a routine, other two, one with the shock waves, the same. The device is the same, sessions the same, the strength is not the same. So it's very there's a big variability. And also there are differences in the monitoring. So now, virtually, an option can be defended and everything can work. So, and at the end of the day, we cannot just say "Oh, it works or it doesn't work, because you always find a study that we defend what to say or what don't say. So with positive confirmation bias, because we normally support what we do on the biography that or the literature that is better for us, and that exactly that's what we like. But there's a consensus about the treatment because the treatment should do a treatment that goes a little by little, step by step. And so there are a lot of studies. After reading 50 of these papers with a lot of contradictions, maybe one paper says one thing and the other one says the contrary. So at the end of the day, you need to be careful with all the publications and in which center, in which magazine, and so on. About the ultrasound guided interventionism, so it can be done different ways with different products and so on. So let's wait a little bit. So where do we do the infiltration? Because we have four points where we can do the infiltration. The first one would be the fat. There is a good consensus that says that no, that we shouldn't work there because we can damage the fat pad. So we should avoid doing the fat infiltration. The second will be fat fascia interface, and we've got a product. You can see that it's like in the case parathenon. And so there is a real reticular space. And so we see this cap, where you can find it deep to the fascia, and then you've got the interfascial ruptures. And so depending on one or the other, to make sense to work on one side or the other. Then we've got a second phase, because how to do the infiltration. We can do the medial approach. That is what we have always done. We enter through medial, looking deep. It's less painful. It can be done without anesthesia. It's quick and easy, because you see the probe and just see the needle. But if you wanted to add the screening, that's going to be difficult, and because you go against the fibers. And then we've got the other approach, the pure plantar. You can do from behind or whatever. I normally do this way, because normally you need to block the posterior tibial, and also it's difficult to see the needle, and then you will you do riddle. So you can do this riddles in a better way, maybe. As a second line for the treatment is that we use corticosteroids, MT or shock waves. And we can speak now about corticosteroids because there are a lot of controversy. If we are going to infiltrate the corticosteroids, I normally prefer these two places, one or the other, or both. Normally, they don't do it inside the fascia, and because an atrophy could happen or a rupture. It exists, and it is described in the literature. And if I go to the superficial uh, plane, I normally go this place here. And if I go to the deeper plane, I normally use corticosteroids that last more in the time. Normally is trigon or betamethasone plus lidocaine. Do we have a controversy with the corticosteroids? Yes, and it is normal. But if you see the consensus document of ACFAS, they say that corticosteroids injections are safe and effective in the treatment of plantar fasciitis. And so, and why is we have this controversy? Because it depends. It speaks about um, the timing, and sometimes the studies have bias because they don't say if they use another measure to control stress, because they say how to treat the symptoms, but sometimes but normally when I prescribe corticosteroids, my patient already has an insult. So regarding the side effects, uh, it is true that we can have a hypopigmentation, fat atrophy, tender rupture, skin inflammation, blood glucose. Oh yes, but the two most important would be the fat atrophy or the tender rupture. And okay, so continuing with that, we see that there was a review of the literature. They studied 18 papers, and they saw that corticosteroid infiltration into fat increases the risk of rupture. And we need to go to the detail. And if you see the rupture cases, normally it's doing sport. So the problem is that there is a very strong movement. So if a stress is done it just jumping, running, doing practicing sport, baseball, basketball, etc. So it is easy to break a fascia there. And in some cases, we form about two, three, four even infiltrations, and normally do one or two, not more. If the first one second one does not work, I'm not going to do a, I don't do a third one. But sometimes we speak about five, but they are patients doing the sport. Another conclusion is if a patient does practices a sport or continues doing, so maybe I'm not going to infiltrate a corticosteroid, but if I've got an old patient full of pain, so maybe corticosteroid is not that complex. As a third line treatment, we can speak about regeneration, PRP, hyaluronic acid, or needling, that is a riddle. It makes sense if you have a look to that. I'm not going to lose the time with this because Miguel explained that, but it is a fibrosis, in fact, and it is what is this already described in all the manuals. And when we've got an injury, we've got an inflammation, and there's healing or resolution. But if this stress that is not resolved, and it always trying to heal, repair, heal, repair, heal, repair. So at the end of the day, it becomes a fibrosis, and so somehow the body decides not to uh, heal in that, and so when the patient is in this point of damage, sometimes we need to make it even more severe. And so when we use severe waves or PRP, that is something that we irritate or epi, so it goes to this point. And so we are going to, what I want to do is try to accurate this injury, so to reactivate these healing mechanisms. And we can do it with all these products and with the preparing. So we fascial riddle, and we do this faster riddle or the insertive footprint. Some time ago, Rubén Montesala, who works in Cordoba, published a paper working on this fascia riddling with the insertive print. So depending on the patient you're going to manage or to treat, you can use this system or the other. And now, as the last line, the fourth one, when nothing works, so you can think about fasciotomy. We're not going to speak that because Francis will speak about that. It is his time with a better explanation, better than what I can do. And about ultrasound guided, there are some of them that are explained by Alvaro Iborra, for instance, on his work with the ultrasound guided plantar fascia released with needle doing punctions that to do anatomy or and answering the question, what do I do? That will be the last of the last part of my speech. How to decide what to do? That's quite complex because at the end of the day, we need to ask, we need to wonder who are we going to infiltrate? Sedentary, sport, work. There will be a lot of variables that would tell I would have to do in every patient. And about how much time do we have? How much time for devolution? So normally, if this patient has been treated for a long time by other colleagues, so maybe it needs to go a step higher, and I need to maybe to take a different approach. And have you been treated before? By whom? How? That's what we're talking about. About the pain. How much pain does the patient have? Is it tolerable? Can the patient live with make a normal life? So I will try. I will see what happens. If the patient comes and cannot walk, I'm going to try to alleviate the pain. And then there is a diagnosis clear. So there's sometimes there are some clients, some patients that they do not improve, and we have to do an MRI, or we have to reconsider the diagnosis, or we have to refer that to another person. And then to clear questions. So is this the patient's expectations? And so normally the patient wants that to be healed in 2 days. So sometimes we need to stop the patients and we need to tell them how to stop and how to make the treatment. And also the cost benefit, and we know that depending on what we do, it will have a different repercussion. Sometimes we speak about the treatment, but we don't speak about the cost it could have. And in order to finish, there are like two profiles. If I have an active athlete, sportive patient, I would just check the control of mechanic factors, the modulation of training load, and how to improve it, and will improve the elasticity. I will then avoid corticosteroids because normally we see ruptures due to sport, and also if to see if we should do faster reading. And about and sedentary patients, sometimes we need to see if the footwear is okay. So if we're going to to prescribe an insole, we need to teach them how to use it and also to do it at home. And also, I'm going to prescribe um, another plantar support, and also, for instance, with the corticosteroids, with the patients that they don't like needles, I can use shock waves. And if it doesn't work, I can use the fascia regeling. If it doesn't work, I should maybe reconsider the diagnosis. And I ask for an MRI or for a blood test because sometimes there is rheumatism or other things. So before a fasciotomy, I have to be sure about the fascia. And that is all. Thanks a lot for your attention. Thanks a lot, Javier. Now we're going to finish within our round table, giving the floor to Francesca Soriano about plantar fasciopathy surgery when the rest of the things do not work.
Yes, but there is little left to say regarding fascia, fasciitis, and some of my slides will move fast. So people here say they love fascias. I hate fascia. I hate patients with fasciitis because they're not. Everything, they're difficult patients really, but there's something that made me change in how to deal with these patients and how to improve their general state. This male, 45-year-old male with sedentary work. He did a lot of mountain sports, climbing, trail running, mountain biking. And he came to me after a mountain trail with acute pain in the plantar area, insertional area of the plantar fascia, the right foot with inflammation, swelling, and functional disability. I performed an X-ray, and we saw a black mass, hypoechoic mass, and this patient uh, caught my attention because it was me, and I had to really learn how to deal with this because I broke my fascia 2 years ago, and I really went through rough times. So I really wanted to see how I could fix this, and I have loads of friends who are podiatrists, and they helped me a lot. So we started treatment. Now I understand. The different stages and of the patients who come to see us, and some of them, have been with this like for 3 years. What have you had done? Nothing. Well, then they never took any treatment of the fascia, so we had to start from scratch. So for me, it's divided into four different stages. It could be five and even six, and we're going to move forward really fast because this has already been discussed. The first stage is when the patient refers pain, which is bearable, 3 out of 10. So we use plantar orthesis. and then review 3 weeks later to see how the patient is evolving. And for me, what really changed my life and now my patient's life, and I like being very clear with my patients, and I have this new therapy, which is the SFA, that therapy that I applied it to myself, and I tell my patients, and you need to apply SFA therapy, which is stop falling around, because all the fascia patients, they want to start running. Oh, now I'm losing weight, I'm starting to. Yes, but you have fasciitis, you cannot run. And I went through this myself because my friends would infiltrate me, and I felt I had recovered, so I ran for 15 minutes for 50k, and then I was not well again. And then insoles, anti-inflammatory, you take ibuprofen, and then nothing. I improved, and then I started fooling around, and then I went backwards like 8 or 7 or 8 stages because I went to play paddle and doing things. So if the patient is always in a rush, and what can we do? You have quite a bit of swelling. We start with corticoids, infiltrations, but patients do not improve, or if they improve, then they feel better, so they want to run the marathon. And I want to run this popular run, and they need to understand, and for me it is paramount, and the patient needs to understand, if they don't help, we cannot help them. We can inject them with whatever, we can make as many insoles as they want, nothing will work, because when the patient stops stressing the fascia, it's all about tissue stress, uh, and there's constant tension and pressure. And once the fascia stops being stressed, that's when the recovery starts. We can, yes, infiltrate and apply some treatments. We can do plasma, different types of plasma and red cells. Um, but for me, my patients need to have had a cohesive sound treatment between 9 to 12 months. And if it doesn't work, that's when I consider surgical treatment that I deal with in my own practice are these three. One is proximal release of the internal gastrocnemius, ultrasound guided fasciotomy, and open fasciotomy, open minimal open. I don't do it myself. This last one, there was a debate if it could be ultrasound guided or not, but this is something we are considering now, and this is something we should span. We shouldn't do it. It's very simple procedure with local anesthesia. It can be done in like 5 minutes. The whole video is 5 minutes, and now it's like two. And we started doing this like 10 years ago. Then I was working with a traumatologist, and he stopped coming to my practice for personal reasons. And this paper was published by Monteagudo in May this year. They reviewed 170 cases with minimum follow-up of 5 to 10 years, with very good results and promising results. So what 10 years ago we started doing with, well, pretty good results, but they seemed it was going to be even much better. I agree with them. Fasciitis needs 3 to 6 months to heal, no matter what you do. Even with this surgery, you need time for recovery. And our patients are always in a rush. It's you extract the internal gastrocnemius, and then we proceed. We cut fascia. We make sure we didn't leave any fiber. Then we suture, And then it's very simple, and the patient can walk since day one. In about 3 to 4 days, they have a normal life, just like I am. They can walk normally, wet bearing, and in about 2, 3 weeks, they can start increasing their charge and back to normal life, even sports life. So this is a matter of myofascial tension. If the whole system bears that tension, now I understand that we need to de-stress not at a fascia level, but in the calcaneal tendon. So in the I'm sorry, in the gastrocnemius. So, and we didn't have back then ultrasounds, as good ultrasounds as we do now, and we started working with ultrasound guided surgery. We thought it was fantastic to being able to have access through such a small little entrance area, but you need to have a very good knowledge of normal anatomy, but also ultrasound anatomy, because what you're going to see in the ultrasound is not the same that you're going to see when you do a dissection in a patient. So we're going to try and dissect 2/3 of the medial fascia with local um, anesthetics or anesthesia. We section the fascia with a knife, and we can see here, this is what we do with we can so with the probe move here, we can see the whole probe being able to go through. We understand that all the fibers have been cut. Looks like nothing is not moving. So what's my experience and my problem that I had? Pretty probably my fault, but what I see is this is the fascia. It's completely flat, as we see here in this diagram. The knife, it's very short. It is not able to penetrate. We've looked for other different options to be able to get further inside. But if we can cut it, it probably would work, would be very beneficial for us and for the patients, because we would leave no fiber. The problem is that when the fascia is not flat, and it has a curve, and we can see it with the ultrasound, but then we touch the fascia, so we're leaving some fibers in the non-sharp area of the knife. So our patient is going to have pain, or even worse pain than before, because the tension is going to lay on top of the those fibers we've left. This is what happened. We did anatomic section even in corpses. Now I tell my students, once you've done it, open the heel and see what you've cut. I want you to make sure that you've cut the fascias that have been cut way too much. They wanted to make sure they cut, so they cut other structures. Sometimes we find fascias with small holes, and the image that we would get was not a real image, it was distorted. And then we found this, which is what I think it's where is the bigger risk, is to have this small fiber if the fascia is too round, and sometimes it can be it's intertwined with the abductor, and so because we could not resect that abductor, then we leave some fibers. So these patients won't have a good result. So after this experience, so many years of performing fasciotomies, open fasciotomy, um, with not so many problems, then I went back to open fasciotomy. And we could classify it as a minimally invasive fasciotomy. It's incisions of 2.5 centimeters. It's not too much. We really don't have too many structures. It's just a bit of plantar fat, and it can be seen. It can be identified, and what I like is that I do see the whole fascia. I can see, as we saw before in the gastrocnemius release, we can see the muscle, and in this case, we're going to see the red fibers of the flexor muscle. We cut the whole tendon, all the tendons, and we check that there's no tension. We can insert a scissor and just to check. And sometimes they think with this incision, the patient has might have problems, and I have had no problem whatsoever because the patient is not going to be weight bearing, and the patient is not going to be weight bearing, like I said. So um, relative non-weight bearing because they start walking again really soon. If there's maybe a bone complication, like in some cases their their bone spurs sometimes, but that's a whole different thing. And then we have the post-op care, other operation first week, which is cure, 5 to 7 days of surgery. I don't let them, it's non-weight bearing. And after that, from 15 to 20 days, I remove the suture and I ask the patient to walk with a boot, a walker boot, if we want, and if it's okay for patient, maybe a normal post-op shoe. As a week after the second cure, and we do the second cleaning, and then we remove the bandage, and they can start using sports shoes if they want. We talk about around 3 weeks. About 3 weeks, our patient should be walking again, maybe with a bit of difficulty. Um, we need to perform an ultrasound check to see how the fascia is doing. Sometimes we find out that the fascia is still as thick as it used to be, but there's no pain referred by the patient. And why? Our patient doesn't have pain because it's not connected with a myofascial tension. Has the fascia has been broken, so there's no way to translate that for that tension to carry to travel. So at about 6 months, a year, if everything is okay, the patient is just having conducting their normal life back to. So now let's just compare both pros and cons of both. The osteotomy, the first one is easy to implement, doesn't need much, which is cut the fascia, easy to execute. You don't need a lot of too much equipment. Scissors, knives, maybe with ultrasound guided, but that's what you need. And then it has minimal exposure and immediate post-op that it's reasonably bearable, and patients don't refer much pain. But recovery is long, and the weight bearing has to be progressive and could be up to 6 months. And this is something that the patient needs to understand because when we resort to surgery is the very last thing. But the post-op needs to be experienced. And so, factors against this is exactly that. And also another uh, um, counterindication is the flattening of the foot. And 90% you're going to need insoles. You can have a possible dorsal impingement syndrome, insufficiency of the windlass mechanism that can, in young patients, can recover. For me, as we humans are stupid. We like fooling around. After 2 years, I'm playing sports again, but I feel more charges, more load in my right foot in the metatarsal area. If we have good anatomical knowledge is important, but especially having good anatomic ultrasound knowledge, it is paramount. Conclusions. For me, surgical treatment of fasciotomy should be the last option to be considered after all the other treatments have been exhausted and needs to be treated by a professional. And the gastrocnemius release nowadays with current research seems to have good results and a good risk benefit ratio. The biomechanical impact of fasciotomy is a factor to be taken into account by both practitioner and the patient. But patients need to understand after a fasciotomy, their foot is not going to be as what it used to be, and we all need to know. The patient needs to understand this. The physician is in charge of assessing the patient's stage and proposing what the best treatment is. We have many different possibilities, but we need to find out which treatment would give us more benefits. And so for that patient, there will be an ideal case, and it is up to us. And even if it's not us who are going to carry out the treatment or apply the treatment, and if what it needs is the gastrocnemius release, and it's not something we do, then we need to be able to refer the patient to the expert, work together hand in hand, and work as a team. So, well, you wanted me to be quick, and now, just to let you know, next week there will be a trail. Uh, I don't know if you've seen it. This is Roberto telling you about this trail coming up soon. This Solidarity Trail, uh, organized by Podiatry Without Borders, 13th of October in Canals. Elena, I'm not sure. Do we have 5 questions? 5 minutes for questions? Yes. Okay. Anyway, so if anyone has a question, feel free to ask any of the panelists.
Okay, so I will ask you a question myself, and so we can put an end to this panel. So Miguel wanted to comment something, as I can see. Just press the button, please. I just wanted to comment something after talking about the thickness of the fascia. I do not agree. There are some studies that say that they've got this thickness because they're linked it to the pain and others not. So we need to know when to see it, when to see it. The fascia is not reduced. If you have a fasciopathy 10 years ago, the thickness is the same. It's like when you have an ankle strain, so a sprain, it is going to be always the same. Ligament will be with the thickness. It is active. That's what I wanted to say. And another thing. that Fran commented this morning. That now you mentioned also Javier. Sometimes fascia is in pain because of the bone compression, and when you do biopsies, they find metaplasia because the bone's compression is also important for our bone edema in the tuberculosis. So sometimes we should have a look to the fibers. I'm going to answer yes. I do agree with what you say. That is why when I said when you see Barrett guidelines, you see thickness but not more. And I see an image says 0.74, and it can say fasciotomy, but I didn't listen to the patient. So I think we agree when we say that after the first year, this thickness will be forever, and there's no point in speaking about that. Yes, but we have the pain. Yes, no, but what about thickness? So be careful about that. Don't speak about that because it will never change. Because probably it won't change. But the thickness is also linked to a clinic, and so that's why I want to highlight that the thickness itself does not give information about what you do. You need to listen to the patient. So I think that we agree with this. And if we assume that as in every pathology there is a compressive strength, there is a tensile strength, and also in the case of an old patient, there's also a problem with the fat pad, and sometimes we consider that the injury is the first back, but it can be in other place because there are a lot of injuries. So many patients maybe do not improve because it's not just the fascia, but because also there is an injury in the bone, bone edema, calcareous, and so on. About that, I would like to comment that I do agree. In a study, we have seen not just the measured fascia itself, but also the deepness, the depth of the fat. And those with um, fasciopathy, they were the lesser fat. So fat sometimes protect. That's thanks a lot. Javier Alfaro, you said that we should keep food elasticity. So we should select the material for the support. Yes, to me it is really important that the material should have elastic memory to be put to be placed under a food. It's a material without elasticity, we have a better behavior. And the risk could be that if there is a movement and more strain, stress, it's will get broken. And Javier Alcala, can we infiltrate corticosteroids into the riddle together? A riddle procedure by local Cojiasa, and I mentioned in the original description use dexamethasone for the post-operative phase to reduce the pain from the riddle. But if you were to try to provoke a response, so there's no point in preparing. So I know I put that in a moment so to reduce the pain. But what I normally do is simple riddling and that's all. If you're going to do that with irritating products like the PRP or so, stop pressing the button. So there is no point in doing both things at the same time. Because with a corticosteroid, you try to get a metabolic answer. So to reduce the pain, but not inside the fascia, but around. Javier, do you think about doing the posterior tibial blockage with a corticosteroid, so to enlarge the duration of the anesthesia? So the idea is You will do a facial brittle. So if you do this blockage, and so if this blockage, maybe it will take a longer time. So as a post-operatory, so to do the blockage on the nerve. If I take the patient and I block the posterior tibial for 20 punctures, so this I'm put this number in 21 because you enter once in once on there, but it is don't mind. We don't need another one after that. Oh, Frances, I think everything is clear. Did you consider to your own operation? No, I did it. I did it. I started from the other way, right? I started with operation when I broke the fascia because the fascia loses continuity. So I needed a recovery process from this surgery, and I didn't understand I needed to distress this ligament and leave them alone so to be healed. They say, didn't you go for operation? Say, how to do it? What can I do? Are you in doubt with the ultrasound guided fascia? Why do you have a doubt on ultrasound guided? No, it's because in my experience was not positive. I don't know. Maybe it was just because I didn't have a my curve is not wide enough, or I don't see the tissues. But the percentage of patients with a postoperative pain, with complaints, so the patient always says they still have this pain. As some of them, I had to do this infiltration with this theory. I said, no, no, it's enough. And so to break these fibers, and when these fibers are broken, it is when they consider that okay. And so I consider that anatomy is correct. We have spoken about different kinds of fascia, and so fasciotomy is done. But if you leave small fibers, the small fibers will support all everything, and so the patient, until it's not broken, the patient is going to suffer a pain that is quite painful, and still didn't happen to me. Yes, I do agree. I have not done this uh, in the patients. I do just a riddle, more or less aggressive, but riddle. And so what I do I keep the wheels and I try to do this kind of longitudinal tenotomy, the tendotomy, and you try to use a thicker needle, and if you keep this stress, it's like doing a largening, but it's not transversal one. In fact, when we did transversals with corpses, we open and we don't cut as much as we thought. So I think it's quite erratic. When you see the ultrasound, you have this impression, but then you opened and Audrey says that you didn't cut here. It's like, okay, fine, but I was sure we had to cut, but you didn't cut anything at all. And so I do really agree. Yes, I tell you this. I think that even it has a bigger sense. And from the mechanical point of view, we need to be clear about that. And we do that with patients that, that we don't, they have no other solution. And that's maybe one month, 1 year, and there is nothing to do in this case. And you've got a structure that does not work. It is a structure with a chronicity of the pathology, and it's a big fasciitis with a elastic, and it's broken. So it doesn't work, and maybe we can break it. And did you ever thought in a walker for 1 month? Yes, did you do it? Oh, yes, I did it. I did it. Um, it worked with an infiltration in a worker. The problem that we have, once again, the idiosyncrasy of our patients. A patient needs to have a worker. Some days ago, one patient decided to take the sick leave. Said, "How am I going to work with a worker?" I said, "Okay, but if you cannot work with a worker, you shouldn't work." Man, we need to understand. We need to speak to the patient because the patient needs to understand that we need to wear this boot for 1 month or even more. And you need to understand that maybe it's going to say, "I cannot. I need to pay my bills. I cannot take a sick leave, or I have multiple works." It is difficult sometimes, but with a worker, that is something quite useful in the USA. You see people on in the street with a worker. They use worker for many treatments. Here, you see one worker, someone who broke a lot. It's not that. Okay, so let's put an end to this round table. So thank you very much to you for it. I think it has been a really interesting uh, round table to finish with this congress. So thank you very much. Hope to see you again in the near future. And I see you showing what you know how to do with this sensitivity and accepted what I asked you from the very beginning, and it has been very easy panel. So I want just to finish. I want to say thank you to all of to them and also to all the speakers participating in this conference from the scientific committee. And this allowed me to say congratulations to Paco Barranco, the president of the Association of Pediatrics in Murcia, because we have been saying this conference with 1,200 participants has been great. So big applause for the speakers and to all the organizers, and please have a nice trip back. So first of all, I want to say thank you to my colleagues in the table, the Marilena Carrascosa, the president of the council, who has been working for us from since the beginning. Marcos Villares, with the same words as that for Elena, it has been an incredible support, all of you. Thank you very much for your presence. Also to Juan Sergio Fernandez, members of Emergencia Andalucía. Also, Correa, Vice President of the Professional Association of Podiatrists. And to Veronica Ruiz Martínez, the President of the Podiatrics Association of Canary Islands, and all the President of the regions that of Spain that are here, and to all of you. I had some few words, but I'm going to make it shorter. After many years of work, hard work, our governing board is really proud of being with you today. It is a period that we finished today. So it is, you say, instead of 2 days, let's be four. But it has to, we need to put a limit. I hope you all enjoyed this conference and that you bring home a lot of new knowledge that you can apply in the consultation that you have on our city and that you would like to come back again in the near future so to learn more and to see our region. So thank you to the organizers, to the organizing committee. It has been very hard, but also the scientific committee that I know they have been working a lot, and it has been great to see what you have constructed. So, so we hope to see you once again, and would like to welcome again to the city. So now I'm going to give you the floor for the awards given for different categories, and I give the floor to Rosario Rodriguez, the Vice President of the official uh, pediatric institutions and the President of Andalusia. Good evening, everybody. Congratulations to the organizers and to Paco. It has been a huge success. So, all of us, we're here, we are professional health carers, and apart from knowledge, we need to show ethics and deontology. Minimum ethics is the one that we ask everybody. That is the one that we all have to show or comply with. And then we have the maximum ethics, that is where we can just see the generosity and the empathy. And the generosity is when you give without receiving. And when it becomes when in generosity, you don't want to receive anything in exchange, but even it affects the well-being. Yes, so when you show that we shift levels that are above what we can, that above the normality. This profession is every year more mature. It's becoming big, but not big because we are a lot, just because we have very important people. Then they leave their houses, their work, their families, their patients, their business, and they go to another place, or they don't go to another place, or to go to the next neighborhood to offer the love, the work, knowledge, without receiving nothing in exchange, or even go to another country to expose their humor.
So now we give the floor to Marco Villares Tobajas. He's the treasury of the and the president of the official um, professional association of podiatry in Asturias. Good afternoon, everybody. So we continue with the presenting the awards. The best poster has been awarded to Miguel García Larrea, Laura Martín Casaro, José Miguel Núñez Moraga, Felix Marcos Tejedor, and Marta San Fernandez, and for their poster for a platform of forces and kinetic parameters in GAFT. ¿Cómo es esto? So now we're going to give the checks to the winners of the scientific gincana of this podiatry conference. And the winners are €100 award are go to Karma Biel Blasco and Alma Arnes Rodriguez, who've decided to donate the award, the prize, or the money they've won to fit to the previous project presented. Thank you very much for this award. It's in the name of Karma and myself, but this is in order to purchase material for the Fit Together Association. Thank you very much. And now we give the floor to Elena Carrascosa for her to say a few words. So now we would like to acknowledge Don Carlos Bellez for his collaboration with the Council in the convalidations of academic records for the exercising of podiatry in Spain. Well, good afternoon, everybody. Just a few words. Thank you very much, Elena Carrascosa and the whole board for this acknowledgement. Virginia, she was the one who taught me this profession, and she taught me. She told me I had to collaborate, and I've met many people who made me step out of my comfort zone, and in order to defend the interests and for the best interests of our profession in the whole of Europe. And I have received more from our from podiatry than I've given, thanks to podiatry. So thank you very much. It's been a privilege. Thank you so much. Now we are going to moving on to something which is especially relevant for us, which is acknowledging someone who's devoted uh, a whole professional career to podiatry. It's a regional benchmark, but also international benchmark because in many cases I could talk about him. And he has defended his values. He's been an ambassador of surgical podiatry, and no one can talk about clinical podiatry without mentioning him. He's an honest person. He's highly professional, and we really appreciate his opinion. He's highly regarded in the in our profession, and whenever you contact him, he's always willing to offer you his support, which is very important for us. So in this, um, I I'm speechless. I'm not able to describe with words this wonderful, extraordinary man, and I ask him to to come to the stage and join us here to receive this acknowledgement from the Podiatry Association of Murcia. So, Francisco Diaz-Bram, Vice President of the Official Association of Podiatrists in Murcia, will present the acknowledgement. So, good afternoon. My apologies, I am slightly moved by this acknowledgement, and I appreciate it very much being presented with this acknowledgement from the 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 Spanish Association of Surgical Podiatry would also like to present you with their respects. I wanted to say a few words because Pedro, for me, has been a friend. We've known each other since I was very young. Uh, he was not so young, but I'd like to say a few words. First and foremost, good afternoon, everybody. Pedro Rivera Plaza it is an honor for me to talk to you about him. He's one of the pioneers in surgical foot in Murcia, and I would say in all of Spain. He's taught us a lot from his work, but also he's taught us about life with his eagerness to improve constantly his extraordinary work and defense of our profession. He is a wonderful person. He's a wonderful professional and a better person. And your endless work and what you have achieved is just astonishing, incredible. So, excuse me, I am a little moved. It's hard to speak. I am fortunate. I have been fortunate enough to work with you hand in hand. Sometimes formally in a formal setting, and some other times in a bit more of an informal way. You have to excuse me, but I love him so dearly. I'm really moved. I'm going to just faint now, just about to faint myself. My apologies. Let me continue. Uh, I keep dearly in my memory many conversations, many moments we have shared. I will always carry them in the bottom of my heart. It's so dear to me. And podiatry has progressed and improved immensely. You've inspired young podiatrists and encouraged them to uh, start and working in surgical podiatry. And so, thank you. Thanks for devoting part of your life to teaching. Thanks for believing in a better future, in a brighter future. Benjamin Franklin would say, "Teach me and I forget. Involve me, and I will always remember." You've managed to get us involved, to have us learn and teach us. Um, and in a selfless way. I once heard you say, you probably don't remember, do not let anyone tell you you can't do something, not even myself. If you have a dream, you must protect it. People who are not able to do things or to do something, they will always tell you you can't do it either. You think you do, go for it. So the Association of Podiatrists and all our colleagues present here, thank you so much for your endless hours and your devotion to our profession. Thank you very much for your efforts, your friendship, your legacy with us. And I would like to finish with some words of Ralph Waldo Emerson. It's not, you can't achieve greatness without enthusiasm. Please maintain your dreams alive further beyond any problems there might be. Always work hard for your dreams to come true. And you, Pedro, you and your dreams came true. Thank you so much for your legacy, and please accept this from the Podiatry Association. Thank you so much. I I will always remember the day when we started the Association of Podiatry. That was a very big day. Thank you. So, um, I suppose many of you have taken part in the ruffle. We're ruffling 3 tickets for next year's edition. So I don't know where the box is. So the innocent person is going to be Paco. I think it's Rosy Millan Suarez, and she just left a contact telephone number. We've asked for an email address. Javier Ballandrino. That's it. Just one surname. And Cristina Cuenca Exposito. We will send her an email address. All 3 of them won a free subscription to next year's edition of this podiatry conference, National Podiatry Conference. Veronica, whatever you need, if you need a hand, I will be the first one to sign up for this National Podiatry Conference. So now we are going to hear from the president of the National Podiatry Association. And that's it. We're just finishing the conference. I'd like to dedicate you my last words. This is the end of this wonderful conference, and it's the perfect time to reflect upon what we've learned and shared together. This has been an enlightening event full of knowledge, but especially full of passion for our profession. We've been able to hear experts from different areas of podiatry who've presented us with the latest findings in podiatry. We've learned about the importance of lifelong training and to be at the forefront in an ever evolving sector, which is like ours. Every conversation, every moment has been an opportunity to improve and grow as professionals. And I'd like to thank all the panelists, presenters, organizers, thanks to the organizing and scientific committee, thanks to the Spanish Council of Podiatry for their support in preparing this conference and these past few days. Their dedication and work has been paramount for us to be able to share this few days. I would also like to thank each and every one of you for your active participation and your commitment to podiatry. Your enthusiasm, your passion is what really made this conference. I encourage you to take what you learned this week, but also take with you the spirit, motivation to support each other and to talk about and spread the importance of our profession. Let's be ambassadors of podiatry and promoting prevention and care of the feet. Do not forget to carry passion in your backpack, eagerness to improve, and get yourself a wonderful team who supports you. Lifelong training will help us create a brighter future for podiatry and make sure our voices are heard. Thank you for your participation, your enthusiasm, and your commitment. I hope to see you all in the 54th annual conference, where we'll continue this learning journey. Let's start heading towards Canary Islands, where I hope to see you all there. Thank you very much, and may you have a happy return back home. So, on my behalf and the General Council or National Council of Podiatry, thank you very much. This is the end of this year's conference.